Bwrdd, good morning and welcome to today's Digital Health and Care Wales board meeting. We're holding this meeting virtually and streaming live. Recording of the meeting will be made available shortly after and accessible via our website. Simultaneous translation is available to allow colleagues to contribute either in English or Cymraeg. In relation to today's proceedings, I'd like to point out that board members won't always be looking directly at the camera. We'll frequently be referring to papers which might be on a different device or actual physical paper. Currently planning to take a 10-minute comfort break after item 5.1 and a 30-minute lunch break after item 6.2. We're aiming to conclude today's meeting by 3 o'clock. And for anyone watching online, I'd like to draw your attention to our annual general meeting, which will be held later today at 3:30, where we'll be showcasing our annual report for 25-26. I'd like to extend a warm welcome to Michelle, Sal, and to Alex Purcell, who are joining us today. Michelle is standing in for Evan Evans, who's not available, and Alex is joining for the shared listening and learning session. I'll now proceed with today's agenda. In terms of apologies for absence, we have 4 apologies. One from Ruth Glazard, who's our chair, Evan Evans, our Executive Director of Strategy, Alistair Class-Neil, one of our independent members, and Marilyn Bryan-Jones, also an independent member. I'll now move on to declarations of interest. I've not been notified in advance of any conflicts. So I'll just pause and see if there's anything anybody wants to raise in relation to today's agenda. Great. Okay, let's proceed to the consent agenda. We're using the consent agenda to focus our activities on business critical discussions and activities. I'm assuming that everyone has read the papers, but I'll just pause to see if anybody has any issues with any of the papers on the consent agenda that they'd like to bring forward to the main agenda. Okay, I can't see anything that needs to be raised. I'll now proceed just to go through those items that are on the consent agenda. The first 2 items are for approval. We are short on independent members today, so we're not quorate. So we will notionally approve, but we'll have to take chair's action post the meeting in order to get full approval of these items. So the first item is the unconfirmed minutes of the board meeting held on the 28th of May. The second item is the unconfirmed minutes of the extraordinary board meeting on the 25th of June. Chris, I can see you've got your hand up.
Yeah, thank you, Chair. It's just in relation to that second item, the extraordinary board meeting, just on page 4 of that, a very minor update. Currently, it says approve the DHCW final annual accounts for 24-25, but that should be 2025-26. So just a minor update there to note. Thank you.
Well spotted, Chris, and we'll get that amended before we formally approve the minutes. Next item is the action log, which we're noting 1 is complete and there are 2 that are still in progress. We're noting the forward work plan. We're noting the Senior Information Risk Officer's annual report. We're approving the emergency planning annual report. Again, we'll do this via chair's action. We're noting the EFPMS return, and we're also approving the annual quality report and the adaptation risk action plan update, both of which we'll do via chair's action post the meeting, unless anybody just check that anybody hasn't got any further comments that want to raise in relation to any of those items. Nope. Okay, great. Let's now move to the main agenda and to our first item, which is the shared listening and learning presentation on planning care learning. I'll now invite Ridian just to introduce this item, and then he will shortly hand over to Alex.
Thank you very much, David. Good morning, everyone. We're going to talk about how DHCW is helping develop digital tools to support the Plan Care programme. Alex will start with a brief overview of what the Plan Care programme is, I'll then go through some infographics of some of the things that we're designing and building in collaboration with colleagues from the Plan Care portfolio, and then Alex will sum up. So, Alex.
Diolch wedyn. Barod o bawb, diolch am y gwahoddiad i rannu y gwaith yma iechyd a gofal Digidol Cymru yn enid i gefnogi raglen adferiad gofal cynlluniedig a draws GIG Cymru. So Plan Care in Wales faces significant challenges. Over 500,000 people are currently waiting for treatment across NHS Wales, and as many patients have multiple health conditions, the total number of treatment pathways that's currently open is over 650,000. While the trend has been that this has been improving steadily over the past 12 months, it still represents a significant backlog, with some patients still waiting over 2 years for their treatment. Welsh Government set clear expectations around eliminating the longest waits, reducing diagnostic delays and improving overall patient experience. So DHCW have been working with the Strategic Programme for Plan Care, which is part of NHS Wales Performance and Improvement, to understand the issues facing clinical staff and to provide the digital capabilities that help clinicians and organisations work more efficiently, more safely, and at greater scale. As Rydian said in his intro, the examples that we'll share today demonstrate that how working with our partner organisations, digital tools have been developed, which will help modernise pathways all the way through from referral to treatment, supporting both national priorities and regional models of care. The backdrop to our work is a recent Welsh Government letter and an announcement that was made by the First Minister, which sets out a clear and urgent mandate for Plan Care recovery. The main priorities are eliminating the waits over 104 weeks, reducing the diagnostic waits to a maximum of 8 weeks, so no patient will wait more than 8 weeks for a diagnostic test, and making sure that reductions in waiting lists are sustainable and then maintained. So they've announced Plan Care recovery funding in order to support that. The priorities are essentially about increasing activity, but also delivering that sustainable transformation and making better use of the capacity across NHS Wales. So to do that, there are a number of operational priorities, which include treating patients in turn and having a better handle on that information, improving theatre utilisation, adopting the Getting It Right First standards across NHS Wales, the announcement of 10 new regional surgical hubs across Wales, and reducing unnecessary follow-ups through approaches such as patient-initiated follow-up and see-on symptoms. The digital initiatives that we're delivering are directly aligned to those national objectives and provide the infrastructure needed to support that transformation. As Rydian said in his introduction, we've got a number of tools that are in development across the suite of DHCW products, and I'll hand over to Rydian to talk through the developments that we're making from a clinician's perspective.
Thank you. So the care pathway starts, the elective care pathway normally starts with your GP consultation, and the GP comes up with a list of potential diagnosis and then referral to secondary care where needed. So we're fortunate in Wales, the national programme has delivered 100% of GP referrals electronically into the system, and we continue to support the specialist care pathways in secondary care to vet those referrals electronically. This has been proven to remove about 10 days in the start of what is called stage 1. So that's from referral to your outpatient. So in a care pathway, 10 days is a long time. 2 weeks out of the pathway improves an understanding of getting the patient in the right place at the right time. So it takes the paper out of the system, it makes the referral legible, and it allows clinicians to assess the prioritization. Prioritization is essentially, are you on a cancer pathway? What is is it an urgent problem or is it a routine problem? And also the electronic system allows specialty-specific pathway coding. This allows aggregated data to understand demand management, and that, of course, helps service planning and provision. It's auditable, and therefore we have dashboards that services can use to see how long it's taking for these referrals to be vetted and prioritized. And because of the coding, we can see the demand of particular things coming through the elective front door, as it were. The other excellent functionality is the ability to support what's known as straight to test. This is where a clinician determines that the patient who's been referred needs, for example, a scan or an investigation prior to being seen. This essentially avoids the patient having to come to clinic to see a clinician, and the clinician then go, well, you need this scan. So have the scan up front, and then have the consultation with the healthcare professional with the relevant information to allow an informed consultation on what to do next. And the other element of this functionality is the ability to determine the type of consultation. Not all patients need to have a face-to-face consultation come into the hospital. They could have video conferencing, or, as was well demonstrated during COVID, the use of the telephone can often help triage and move patients along the care pathway. In addition to this, there will be times where your patient will come into a specialty, and during the consultation, it will be apparent that they actually need a different specialty or an additional specialty. And hospital-initiated referrals is functionality that's being piloted in some of the health boards to be able to move the patient around the system electronically rather than the traditional view of clinic letters being either put in envelopes or emailed. Next slide, please. So I talked about accelerating the pathway straight to test. The clinician looks at the record, is able through the single care product to be able to review the documentation, care documents, the previous tests, and to organize a diagnostic test. Commonly, this is radiology. So they do that and then record in the template the fact that the next step is a straight to test. It is not straight to outpatients. What we're trying to avoid here is tests being requested and then the patient coming to the outpatient before the test is reported. That's a waste of everyone's time and the resource. So the new functionality allows the recording of straight to test in the patient administration system, and that means booking clerks will not book the patient until the test has been done, reported, and the clinician has decided on the next step. And this is a really good way of improving capacity to see patients when they need to be seen without increasing the workforce. You'll notice from the little box on the right-hand side in the very bottom, there are administrative comments that the clinician can personalize, and also enter comments which are then shared with the GP. So the why I'm doing something, putting you straight to test, is shared with the GP, and that obviously enhances the two-way communication between primary and secondary care. Next slide, please. So having had those tests, you come to outpatient. This is a product that is live across Wales, and what's useful about this is we go down it, you'll see there's a tick box for multi-professional clinic. So you might come to a clinic and see a physio before you see the consultant, and this allows for multiple professions to record within the same clinical event. It also allows us to record the actual type of consultation. We talked about telephone, video where possible, face-to-face, or is this an office-based decision related to the outpatient? And therefore you can enter it. Where it says add the new entry, the ambition would be to include voice dictation, potentially ambient voice dictation, and then to record the outcome of the consultation. Now, if this is done on this functionality, then the visibility of this is instant across Wales. So currently we have 44,000 unique users of WCP. So you're in, say you have a consultation with me in the urology department, I fill this in. By the time I've saved it, it's visible throughout the secondary care environment. And should you present to another clinician the next day, for example, my decisions would be visible. This reduces, of course, a requirement on typing, and but it does put an onus on the clinician to actually do it. But remember, our primary care colleagues have been doing this for years. They've been typing directly into the record. So it's a change perhaps for the clinicians in outpatients, but it comes with some real benefits. And the ambition then is to be able to share that with the patient, so and directly electronically with the GP, and that functionality is being explored. Next slide, please. So you come out of the outpatient's appointment, and commonly across NHS Wales, what happens is a clinician fills in a piece of paper. And it'll probably be no surprise to you that clinicians are not very good at filling in bits of paper, particularly ticking the relevant boxes and making it legible. So an electronic outcome form allows us to assess, did the patient come, and what the working diagnosis was at the end of the consultation, allows us to see if that maps to the original referral, whether or not that patient is on a cancer pathway, should continue on a cancer pathway, or needs to be actually upgraded onto a cancer pathway, and that has implications for the referral to treatment time, and then to nudge clinicians to discharge where appropriately, and use the C-on symptoms and the patient-initiated follow-up, something called PIFU for short, which allows the patient to get back into the system. There's nothing worse than a patient who comes back for follow-up and they say, oh, well, actually, doctor, I wasn't sure if I needed to come. Nothing's changed. I'm quite happy. Thank you very much. That's a waste of everyone's time, and that's stopping new people being seen. So by nudging the use of C-on symptoms and patient-initiated follow-up, you can actually increase outpatient capacity without increasing the workforce, because you're seeing patients, the patients that need to be seen. And also the ability here at the bottom, clinicians can put in notes, and that can assist them when they're reviewing their follow-up not book list, which is a massive problem. Those are patients who are waiting to be seen again. Right, next slide, please. So you see a surgeon, someone like me, and we decide actually together that you need an operation. Currently, we use cards to fill these in. Again, I go back to it's paper. It's often there's a problem with legibility. Not all the things are necessarily filled in that allow stratification of the risks associated with that particular patient, should they be going to have an operation. We were asked by the Surgical SIN, that's the Clinical Implementation Network, which is out of NHS P&I, could we put together an electronic waiting list card? So we've designed this with stakeholders to the Royal College of Surgeons standards. So there are some certain things on there that are absolutely relevant to be able to schedule patients appropriately in certain care environments. So one of the biggest issues that we have is identifying things that are going to stop you having the operation on the day. And you'll see that specific operative risks, that bit at the bottom there, talks about diabetes, need to be first on the list. You've got an allergy to latex, that needs to schedule the use of different type of equipment and airflow in theatre. You might have a pacemaker, which might need to be checked before you go in and reset after you've had the procedure. And there may be drugs that you're on that make you bleed. Obviously, surgeons don't like drugs that make patients bleed, and you've got to make sure that they've been stopped in appropriate time to make sure that problems are avoided. So this has the potential to make care safer, to improve an understanding of the demand management, and to look at the scheduling of theatres. So we're going to work initially with the orthopedic community, as they've got a specific list of codes, and they've mapped those codes to a particular theatre type. So for example, you might have a half a knee replacement, and you might be able to do 3 of those on a theatre list. So if you know the time of the procedure, the type of procedure, you can use that very expensive and limited facility of theatre time much better. And that means waiting lists will be shorter. And that also allows us to move patients around the system remotely. So what's on the waiting list for procedure X? Can it be done in a remote surgical hub? Yes. Can that patient be scheduled to go to that different care environment, meaning they get their operation sooner? And so that's the thinking behind having an electronic waiting list card. Next slide, please. So previously we've discussed the planned care program objective of perioperative assessment, the ability to optimize health conditions before the patient has an anesthetic. Classically, you would think about making sure the patient doesn't smoke or tries to stop smoking before their operation, or there may be a weight reduction, or there may be an improvement of blood pressure control, those sort of things. Things that improve the patient safety in terms of getting through the procedure. And again, of course, this supports theatre scheduling because you can classify patients by certain risk, and therefore they can go to certain care environments. This again supports theatre efficiency and helps us with planning. And vitally, it minimizes cancellation on the day of surgery. There's nothing worse for the patient. They've built themselves up to have an operation. They come in and they find at the last minute something's been overlooked and they can't have their operation. That's a waste of their time. It's unhelpful, and it is a waste of the valuable, expensive resource of staff time and theatre. Again, I said this supports regional working. Previously, we presented at these boards the fact that 1 in 5 patients has their care beyond the health board that they originally register. And of course, regional hubs is going to need the visibility of the record for where the patient goes. And this is an all-Wales approach led by anaesthetist. Claire Dunstan is the clinical lead for this in collaboration with the other support services and SINs. Next slide, please. So you actually go and you have your operation, and then a surgeon writes it on paper. And at the moment, only 2 of our health boards are recording and sharing the operation note in an electronic format. And this is a vital bit of information. We want to know what you had done, when you had it done, and what they actually did. And this has been designed with the surgical SIN, again, aligning to the Royal College of Surgeons standards. It will improve patient safety. It promotes the use of the World Health Organization safety checklist. To explain that, everyone identifies who they are in theatre, what they're there to do. Do we know who the patient is? Do we know what they're here to have? Have we got the relevant equipment? Is there anything that we're not expecting? Have we thought about antibiotics to reduce the chance of infection? Have we considered the necessity for blood products? Have they got thromboembolic prophylaxis, be that stockings or certain other surgical equipment? And then when we put implants into patients, some of those need to come out. And people on the call might be familiar with the pelvic mesh issues, the breast implant issues, the metal hip issues, and that have come to light many years down the line. How do you identify who went, who had what put into them when, so that you can bring them back and review them? So that operation has been designed with the view to support the Scan for Safety program, which is a policy objective. Next slide, please. I'm going to hand back to Alex, because after your operation, you've had your definitive treatment, and that is the end of your care pathway.
Thanks, Rudian. I just wanted to say a few words on the regional surgical hubs and the work that we are doing at the moment. It's very much in its infancy, but we have started to take steps to engage with health boards around their plans for those regional surgical hubs. So we have been working predominantly in the first instance with the South East Wales Regional Partnership, who have already established a regional working hub in Nair and Bevan Health Board in Neville Hall Hospital. So that takes patients from the Aneurin Bevan, Cwm Taf and Cardiff and Vale waiting lists, and if they meet certain criteria, which could be but aren't at the moment recorded on the waiting list card, they are then eligible to receive their treatment in a high volume, low complexity clinic. We have started some discovery work about what we can do to potentially streamline the process, because at the moment, booking clerks in the office in Aneurin Bevan are moving patients between PASs manually, as well as the Cardiff PMS system, using a mix of spreadsheets, Microsoft Forms, and the actual digital systems. It's a complex and challenging environment for people to be working in, and at the same time, they're handling calls from members of the public who have queries about their position on the waiting list, the status of their appointments, etc. So there's a significant risk of transcription errors, etc., within that process. So what we're then seeking to do over the course of the summer is discovery work. So we've established some regional working groups with DHCW colleagues, as well as colleagues from the regional working partnership, so that we can get a clear position around what the requirements are. We've got one eye on the future for this, because we know that there's likely to be 9 other surgical hubs that are established, Llantrys and Health Park for trauma and orthopedics being the next in the pipeline. We want to identify what is ophthalmology only or cataract only issues, and see whether or not they can be addressed. But we don't want to go too far down the road of delivering a bespoke solution for the cataract regional working and then have to replicate that 10 times. So we're investigating ways that we can future-proof that activity by engaging as early as possible with all of the regional working partnerships as they mature. As I say, this is work that's kind of embryonic at the moment. We're very much in the discovery stage. However, we're hoping that by September, we'll be in a position to understand exactly what the requirements are. We might have potentially identified some quick wins, which might streamline the process within the regional booking hub. And then we'll be working with the regional working partnerships on plans for delivering potential software updates and changes to help streamline that process. Next slide, please. And then just a final slide. So each of the capabilities that we've discussed supports one or more of NHS Wales Plan Care objectives: reducing delays, increasing productivity, modernising services, improving data and performance management, supporting regional models of care, and ultimately improving outcomes for patients. Taken individually, they're discrete digital developments. However, collectively, they form a coherent programme of work across the portfolio that supports the transformation of plan care pathways. From a DHCW's perspective, this is a strong example of our organisational purpose in action, making digital a force for good in health and care, supporting clinicians to deliver better services, and helping NHS Wales meet the needs of patients more effectively. Diolch.
Right, many thanks, Rydian and Alex. Really interesting presentation, some huge potential there, I think. I've got a question myself, but I'll just pause to see if anybody else wants to ask a question before mine. Marion.
Diolch, Cadeirydd, a diolch Alex a Rydian am gyflwyniad ardderchog, diddorol a defnyddiol dros ben. Mae'n ddiddorol gweld effaith yr rhaglen waith yma a'r symleiddio a hwyluso taith y claf drwy'n system gofal iechyd. Mae'n nghwestiwn i falle yn ymwneud â i ba raddau yma'r byrddau iechyd a'r sefydliadau i gyd wedi mabwysiadu'r rhaglen waith yma. Rydian referenced that 2 health boards, for instance, had adopted the operation note, which is clearly a potential game changer in terms of quality of information being shared across NHS Wales. What are we doing to influence an increase in take-up of the use of the operation note and some of the other pathways that we've heard about this morning? Diolch.
Thank you, Marion. As always, you ask a question that has many strands to it in terms of its answer. So the first thing I'll just clarify, we've developed the operation note. The 2 health boards that I mentioned have their own system, and that exports their system's operation note into the single record. So what we've done here is we've worked with the surgical SIN to help those surgeons who haven't got access to those systems. So the surgical SIN, the clinical leads there have taken it back to their health boards, and they're working out with their digital teams as to whether they will be allowed to switch it on. So we design the product, but we don't switch it on. It's a local choice to do that. The electronic waiting list card, that's again a NHS P&I driven program, and once they've agreed to the full development of that, they will drive its implementation. And this is often the case with all the things that we do, is that we build them because we're asked to build them by the stakeholders, but there are local decisions as to what's switched on and used. With the development of the regional partnership boards and the new political objective of moving patients around so they get high quality care in the shortest period of time, these tools are absolutely imperative to make sure that there's visibility of the care information. We're working hard with the anaesthetic SIN as I how can we do it quickly? How can we do it cost effectively? How can we make it sustainable? How can we make it secure in terms of cyber security, etc.? And of course, the current platform, the single patient record, is visible in all health boards. But as Alex pointed out, there are some health boards who have a different PAS system, different coding, and these things are always a slow burn.
Thank you. I guess my other question, supplementary, if I may, Chair, is about the value that is being derived from the Pathway programme. And we talk often, don't we, about how challenging sometimes it can be to demonstrate the value. And perhaps we could talk about how that's best articulated, and to what degree we are successful in demonstrating and evidencing the value of what we do.
Well, I think the first slide that I spoke about in terms of electronic referrals and vetting, we've clearly demonstrated that you can turn the referral around very quickly, and that you can put the patient in the right place for the next step. And that has a visible impact in terms of a reduction in the waiting time, which obviously is measured in the referral to treatment time.
Thanks, Rydian. Helen.
Thank you, Chair. Yeah, really good to kind of walk through that process in terms of the planned care pathway. So my question was for Alex, actually, and the regional work, and given the focus on that at the moment, really good to see the discovery work through the lens, sorry for the pun, of the eye care services, particularly in South East Wales. So I guess the expectation there is that we will be able to understand what it is we're trying to achieve in terms of the integration of the information that's needed to manage pathways across organisations. And that then, I guess, will give us a clear picture of where there are gaps and where there are potential already developed national modules, functionality that could plug some of those gaps. Is that kind of how you're seeing this work evolve?
Exactly that, Helen. So this, I suppose, the process that's been established by the regional working hub is one that has been developed based on the systems that they've got, and clearly there are gaps there, and there were quite a few. I went to visit the regional hub with the team myself, and saw, as well as some colleagues on the regional working partnership, and we saw that there wasn't necessarily alignment between what the sort of documented process map is and what actually happens on the ground. So the intention will be that we identify those gaps. We think about what the future looks like as well, rather than just making fitting a use case that works for regional ophthalmology, but ignores what the needs in trauma orthopedics or general surgery for hernias might be. So yes, by the end of September, we should be in a position via a series of workshops, engagement sessions, visiting the site, have a clear articulation of this is the problem, this is what we're seeking to solve, this is how we're seeking to solve it. There might be, I guess I'm putting the cart ahead of the horse a little bit here, but there might be some, things that we can do now, some things that are slightly longer term, that might have more broad applicability, and we'll see where we go from there. Essentially, it is very much early days. But to go back to Marion's previous question around benefits and value, one of the things that we're keen to do as part of this discovery activity with the regional hub is to have a clear understanding of what we've got in terms of data quality issues now, incidents relating to transcription errors, some of those things that we know are currently happening due to the sort of swivel chair interface that we have with the multiple systems being used, as well as general times between bookings and those sorts of things. So we're looking to get a series of baseline measures in place, and then as we roll out the agreed functionality moving forward, we can revisit that and get a proper capturing of benefits to move forward. And that's something that both we're interested in from a DHCW perspective, but also the regional working partnership are keen to demonstrate as well. So it's at the forefront of our minds with all of these initiatives within the Plan Care portfolio about mapping those benefits out. Some of the challenges obviously are that we're moving in some areas from paper-based systems to digital systems, so it's a bit more difficult to get that data quality. But absolutely, it's the intention to measure everything moving forward.
Thanks, Alex.
Great, thanks. Let's go to Chris Morton.
Thanks, David. And it was just building on the 2 points, actually, one from Marion around value, and Alex, you did touch upon it there. My question was actually, do we have a view at this stage? Because the planned care sector across Wales, there's a key focus on productivity improvements. So do we have a view at this stage of the quantitative productivity benefits, or is it planned that would be developed through the discovery phase?
It's planned, Chris. I think there are other things that we've done in the background around data standards, not highlighted in the presentation today, to get better information about referrals and activity within Plan Care. So changes have been made to the PAS system to accommodate that. We're expecting that information in those areas will start to flow through from the end of the summer, early autumn. We'll then have a good understanding of what current activity is, and then across NHS Wales, everyone will be comparing apples with apples, and then we'll be in a position then that we can start to measure that improvement through regular monthly returns on the Plan Care data sets.
Thank you.
Great, thanks, Alex. Sam Lloyd.
Thanks, Chair. It was just also on the value point, actually, just to say that we've done quite a lot of work across the Plan Care portfolio, but more broadly across the single record suite of products to start to define the areas where we think value is being delivered. And we've made some assessments and some estimates of, for time saving for clinicians and so on. But the next step is to validate that on the ground, because that's the only way in which we're really going to be able to stand behind any statements that we make. And where we've done that, for example, with the Welsh Nursing Care Record, that's been quite successful. And we have worked with teams on the ground to actually properly define the time saved and other areas of value that are being delivered. So we know that there are efficiencies which are probably not cash releasing. There may be some cash releasing elements to this as well, but as I say, we need to work with teams on the ground to properly define that. That's going to become a responsibility of product teams. We're making some internal changes which will help to bring that about, and we're also going to be bringing that out through the product reporting. So that will be making its way up through the portfolio oversight, through PDC and so on. So we'll be starting to surface that in the coming months.
Right. Thanks, Sam. Brilliant.
I just wanted to come back on measuring value. It's a tricky one. We don't measure how many patients turn up to an outpatient's appointment and get nothing out of it. That's a waste of their time, and it's a waste of the resource. I'll give you a little anecdote as we're finishing off, David, if you wouldn't mind. Yeah. A patient of mine required a procedure in the radiology department. In taking a history, it was apparent that this patient had the procedure elsewhere. previously, and that was needed for comparison. The consultant radiologist asked the secretary to see if she could get the report and imaging. The secretary emailed another secretary, and then that secretary was off and had to ring someone else to see if they could. And essentially, the pathway involved nearly 10 people. If you put the outcome of a care event in the record, it's instantly visible. You deliver benefits which are not tangible, perhaps through a metric, but I can tell you what, they make a real difference in the delivery of care.
Okay, thanks, Rydian. My question was related to value, so I'm glad everybody else focused in on that. The supplementary to my question was, if we're able to articulate the benefits of some of the stuff we're developing, that I think will help the uptake from other health boards who might then see, oh, right, okay, there's some benefit to be had, and that might drive our uptake. So that was my thought on the topic. Thanks, Rydian and Alex, for the presentation. I found it very informative. And if there's any chance you can come back downstream and give us an update on where you've got to, I think that would be extremely useful. Okay, so the board is being asked to receive and discuss this shared listening and learning session, which we've done. So I'll now move us on to the main agenda, part 4, which is the vice chair report, and use of the common seal. In Ruth's absence, I will briefly just pull out a couple of highlights, assuming that the papers have been read. First item is the board arrangement. As people will be aware, we are in trying to recruit a replacement chair for the board and an independent member position, which has been vacant since earlier in the year. I'm pleased to report since the last board meeting that both posts have been advertised. Shortlisting is in progress and interviews will be held in the near future. And it's hoped that those positions can be filled during Q3 25-26, which will bring our non-officer executive complement, i.e. our independent members, back up to the full complement. The other two things I wanted to mention from Ruth's report relate to the extraordinary board meeting we held on the 25th of June to approve our annual accounts, and our board development day, also on the same day, where we focused mostly on our escalation status and the IMTP. With regard to my vice chair report, there's two things I wanted to pull out, which was with my role as chair of the Portfolio Delivery Committee, I've been holding program risk tolerance meetings with all our major programs. This was something that was requested in our remit letter. We're pretty much complete, apart from one, which I think is next week, which is the LIMS meeting. So those are the only things I wanted to pull out. I'll just pause and see if anybody's got any questions. Rydian, is that a question or is it a legacy hand? No, I thought. Okay, great. In which case, there's no questions on the chair and vice chair report. So with that, I'll move over to Helen for our Chief Executive Officer report.
Diolch, Chair. Thank you very much. Just I'll pick out some highlights as colleagues have the report there. And one thing that I'd forgot to include that I will touch on as well. The escalation status will remain at level 4, as the board is aware, targeted intervention. I know we've got an update from Chris, our SRO, on that later on the agenda, but just to say that we've been progressing the work with NHS P&I predominantly. They're working with Welsh Government to move that process forward, but we have been engaging more widely in the organisation so that the board, we've spent a fair bit of time as a board on our escalation status and the improvements that we would want to take forward, but also the wider organisation to make sure that staff and our senior leaders understand where we are and what improvement priorities we are taking forward as an organisation. And just want to thank everybody for leaning in, actually, across the organisation in terms of the work that is being done in this space. I also wanted to touch on the primary care summit that was held around just over a month ago in Welsh Government. So myself and Sam Hall attended the summit that was led by Welsh Government, and all three of the Cabinet Minister and the two Deputy Ministers for Health were there, and actually the First Minister came along to introduce the session very briefly, bless him, because he'd lost his voice that week. I think he was feeling a bit under the weather, but it was a really good session with many of the senior leaders in this space across Wales attending and workshopping some of the priority areas and the improvements and transformation priorities that we could and should be taking forward together. Just this morning, actually, we've had a letter from the Chief Medical Officer, who kind of led the Case for Change and is leading on the Community by Design transformation programme. The summit endorsed the Community by Design programme to continue to move forward, and I know Sam is going to talk us through a bit more detail of the work that's going on in that space as part of her report. The letter from Welsh Government, it came out from the Chief Medical Officer and from the Director for Primary Care in Government, sets out two of the early priority areas that Government are going to take forward. The first one is NHS P&I will be out to advert next month for a director that will be responsible for this area of work within the P&I structure, and for the Welsh Government to move forward on the IG framework so that it is clear what legislative change would need to happen in terms of data sharing and data access, and for that framework to be set out by October 2026, all of which will be overseen through the Community by Design programme. So really good to see kind of that energy and focus to move that forward from the new government. Also been quite a busy time on the NHS Wales Digital Blueprint work that the Chief Execs have commissioned. So quite a lot of engagement that's happened right across the piece. Around 300 people, I think, across Wales have been engaged in the discussions and the co-design workshops that have been held over recent months. We've now got a draft set of outputs from that work that had been shared and socialised and are being refined by our independent colleagues who've been developing those outputs on behalf and leading the engagement on behalf of the Chief Execs. So, and we met with colleagues from Government, with our taxology colleagues a couple of weeks ago, and they were really pleased to see the progress. We're going to take it to NHS Wales Leadership Board at the end of August for a wider discussion with all of the Welsh Government Health Group Exec Director team and the Chief Executive. So really pleased to see that. It will, and I think the conversation has reinforced how this work will help to drive delivery of the new strategy, the 10-year strategy that the new government have recently commissioned, that is now being developed by independent consultants. So I think that's really helpful that we'll get those things coming together, because having that North Star was actually one of the top areas that came out of the work that we've been doing through the digital blueprint. So I think that's it's really effective, and we have that going forward in parallel. The other thing to mention, just quickly, it was fantastic actually, and thank you to board members who attended the Staff Recognition Awards earlier this month. It was really great to see so many of our staff attend and enjoy the Recognition Awards, but also the amount of nominations that we had was phenomenal, and congratulations to all who were nominated and all who won something on the night. It was really great to catch up with so many people. And just the final thing was that we hosted the chairs and chief executives earlier this month with the initial introduction meeting for them with the new cabinet minister and the two deputy ministers and the NHS Wales chief executive. So that was a really, really great conversation, and good to see our facilities being used by the wider NHS as well. So yeah, really, really helpful to hear directly from the three ministers of their priorities, and that focus and the energy and passion came through really loud and strong, really. And the the focus on valuing the workforce that is operating under what are quite significant strains and pressures at the moment. So it's really helpful to have the opportunity to hear new government's priorities and for chief execs and chairs to share where they think the priorities are for moving things forward and improving. So yeah, that was it. Happy to take any questions, Chair.
Okay, thank you for that, Helen. Maureen, you've got a question.
Diolch, Helen, am yr crynodeb clir iawn o'r cyfoeth o weithgarwch sy'n digwydd o fewn DHCW. Dau gwestiwn os cai. Un yn ymwneud â'r pwynt ola un, mae'r cyfarfod efo'r gweinidog a'r ddau ddirprwy weinidog. A'r drafodaeth ynglyn ag blaenoriaethau y sector. Faint o unoliaeth sy'n yna o ran blaenoriaethau'r sector ar draws Cymru, achos mae'n amlwg mae hwnna'n mynd i effeithio ar sut y ni yn gweithio ac yn gallu cyflenwi yn amcanion ninau fel sefydliad. A'r ail gwestiwn yn ymwneud â'r cyfarfodydd i chi wedi bod yn ei gynnal efo staff ac uwch arweinwyr i drafod ein statws uwch gyfeirio. Allwch chi ddweud rhywfaint ynglyn â beth ydy lefel y dealltwriaeth o'r heriau sy'n yn wynebu ni ac faint o awch sy'n yna i fynd i'r afel. Wy'n cael yr argraff bod yna awch cry iawn o ran y sefydliad, ond byddai'n dda clywed y ymateb chi ar ôl bod yn siarad efo staff ac arweinwyr. Diolch yn fawr.
Diolch, Marianne. Yeah, two great questions. I would say in terms of the first question around the unity across the priorities, I think there is strong alignment across priorities. I think we all, whichever kind of space you're occupying across the system, we all understand the challenges and the pressures and what it is that we're wanting to achieve. What I was really pleased to hear was the prominence of digital and data in the priorities coming from the Cabinet Minister and both of the Deputy Ministers. And we're really clear that we cannot move forward and sustain, improve and transform health and care services without digital and data. And data is really prominent in the discussions that we've been having right across the board. Hence, really, the outcome from the Primary Care Summit about data sharing and data access. So that came through really strongly. It was the number one on a list of 6 from the chairs in terms of their priorities. So digital and data there, and was in the top list for chief executives as well. So I think that there is we're having open conversations about the fact that digital is at the heart and data is at the heart of how we make the changes that we need to make, and you can't do any of this stuff without that. So digital first, but not digital only, I think is one of the design principles of community by design. And I think that's one we can all definitely relate to. So I would say there is a great deal of unity in terms of the priorities. The conversations with staff and senior leaders. So we've stepped up. I've stepped up some of the more informal communication with our senior leaders as well since we've been escalated. I think it's helpful for everyone to have that kind of safe space where they can ask questions about where we are at the moment, and we can share, because there's quite a lot of activity that's going on. We're asking for a lot more, inevitably. We're under targeted intervention level 4. It's going to come with more scrutiny, more reporting that we need to do. So there's been quite a lot of activity that's been going on. So the full context and the understanding that we have of where we are in the process, I think that is paramount to share with our teams across the organisation. I think it's true to say that there was a lot of disappointment from our teams when we were escalated further from level 3. I think that we are, a relatively small organisation, and we work very closely, organisation-wide, don't we? And I think for some of our colleagues and indeed the team, it feels personal, doesn't it? It is, we are here to do the best that we can in terms of discharging our statutory duties for the people of Wales, isn't it? And for our families, for our friends, for our staff. So So the mission is really clear, and I think our staff feel the importance and the significance of the mission that we have, each and every day. So they feel it, I suppose, Marianne, but we also know that there are things that we need to improve. So we are open to the opportunity that this gives us in terms of the improvement to move things forward and how we can get the clarity alongside the improvement for us as an organisation, but the clarity that's needed specifically around roles and responsibilities, I guess. And that's where I think the blueprint work is really helping to surface some of that as well. So yeah, it's been a challenging time, but it does feel the organisation is responding positively.
Thank you. Yeah.
Great. Thank you for that, Helen. I can't see any further questions, so we'll move on. Board's been asked to receive your report, which we've done. The next item on the agenda under strategic items is 5.1, which is the primary community and mental health report. And for that, I'm going to hand over to Sam Hall.
Diolch. Thank you, Chair. Thank you for giving me the opportunity to give another primary community and mental health update. In interests of time, and because I have been known on occasion to talk too much about this subject, I'm going to focus on a few areas from the wider report. But the main one, I think, to pick up on what Helen said, because it is so important, probably one of the biggest areas of transformation across NHS Wales currently is the Community by Design programme of work. I can't stress how big the focus is currently. Many areas across the DHCW, including just mine, not just mine, are involved in areas of work in Community by Design. We've got clinical and strategy already kind of deeply embedded in some of the work. We're forming a truly multidisciplinary team for this significant piece of work, because we have to. It's across everything. I mean, it's shaping up to be an impactful program, I would say, and we're seeing kind of significant change starting this year, which the Minister has asked for. He's been very, very clear, very directive on where we're going with this, and it's not about talking about it, it's about delivery. So we can see this already starting to have an impact in health boards, and it's an extra pressure, I would say. It's not something we all foresee being quite as big as it is. So myself and Helen are engaged at a senior level on either the Programme Transformation Board or the Reference and Advisory Group. But actually underneath that, there are layers of assurance and delivery groups that we have people embedded in from across the organisation. So we are at pretty much every stage and every layer within the programme. The three main pillars that are being led are in prevention and population health. So you can imagine there that the huge impact that has on data, and the need to share data effectively, and to have good data standards. And for us to be involved in that means not only wrestling with the issues around data sharing, but also to make sure that when we're talking about solutions for delivery, that we don't have a huge proliferation of this and introduce more confusion across Wales. So it's very much using our kind of digital skills and expertise to really try and direct this in a way that will get the best outcome. Urgent and same-day care is another one of the themes, and you've just heard through the planned care piece around how important management of some of that is, and how the flow is really important to making this work. And we've got people working in that space currently, and working very closely with WAST as well on how we try and square the circle on getting people to the right place at the right time. And then chronic conditions management. Our lead AHP in this space has been absolutely brilliant at being able to understand what that means in the community. You're out of a hospital setting and you're going to live with long-term conditions for a long time. What does that mean for you, for your life? What are the best ways that we can help you to be able to have a long and fulfilling life, but actually not having to rely on going back and forth to a hospital all the time? So these are all really important. And as you can imagine, digital and data capabilities run right the way through all of them. They are fundamental enablers for these ambitions. Without them, you cannot do it. So we are integral, I would say, to the delivery of community by design. And so, it's as it moves into the next phase, which is around engagement and sharing of the models that are being developed, that is where we're going to really start to understand the impact this will have on patients and clinicians. So it's really important that we stay absolutely fully engaged with this. But I guess the headline here is that it's not funded. So community by design is not a funded program. It doesn't have a big pot of money. A ministerial decision has been taken that health boards will move 0.5% of funding from secondary care into primary care. That's not so easy for DHCW because we don't have our funding set out in quite that way. Not that it's simple for health boards in any way, but it's more difficult for us to do that. So we are currently working through best endeavours, and the next phase for me and the team is to come up with a plan for how we manage this and a steering group within DHCW, so we make sure we're across the things we need to be across, because it's not going away and it is gaining pace and impact. So we're having to put more effort in, but it is incredibly exciting. And hearing the minister talk about service design being at the heart of this, but that's where we come into our own. And also that this is a generational change for healthcare. So for DHCW to be part of this, it's a no-brainer. We absolutely need to be part of this work, and we very much are. So that's kind of the point one I wanted. The other one one of the other things I want to talk about is eye care. This is obviously always a hot topic. I know it comes up in the kind of chairs and vice chairs meeting from time to time, because it's been something that has been going on for a long time. So as of late June, Opera, the referral system for eye care, was live in all health boards apart from Aneurin and Bevan. But Aneurin and Bevan have confirmed go live now for the 5th of August. So there will be all health boards will be live on the same system, so nationally across Wales, which is just a fantastic opportunity for us in Wales, and a really good thing to be part of. So about 9,000 referrals have already happened and been processed to date since that go live, and now we're moving our focus onto the secondary care part of it. So so one of the big things here is to agree a national set of standards that can be adopted across all health boards. Obviously, that's going to make it much, much easier for us to, whilst it's a sensible model anyway, we would want it will allow us to roll this out much more quickly and more safely, because we won't be trying to adapt several different models to try and get rollout. So one of the big focuses, and with support, actually lots of support from Welsh Government now, is that there is a nationally agreed model for this, which is excellent. And a piece of work we're just completing now is to simplify the referral forms into GPs. So currently they are sent by mail, then scanned in, which is just really, it's cumbersome. It's not a great way to do work. So what we've moved now is to enabling practices to move to something called DocMan. DocMan Connect, which actually just drops the referrals into their workflow. So this will take, it's one of the things that Rydian talked about in the planned care space. The seamlessness of those things happening and taking the paper out is of a massive benefit. Obviously, we've got some key dependencies here. So continued health board engagement is an absolute must, is essential. As we know how stretched teams are across Wales, digital teams and eye care teams are stretched, to breaking point in some places. They have a lot of priorities. Agreement on that pan-Wales approach, that model will be, it's not only sensible, but it's safer and better for patients. And it would mean we can roll this out in a more assured, speedy way. So, getting that again, really important. That said, I'm really proud of the work the team have done on this so far. It's been done so quickly, with a huge effort, not just from our team, but with Welsh Government and health boards to adopt this so quickly. It's, it just shows what you can do when there is some impetus behind it. So that's in the eye care space. I was just going to touch on the NHS Wales app. So patient registrations have reached 811,000. So by the end of quarter one, so that exceeded our target for quarter two. So we're a quarter ahead and over. So that's a really good news story, and it shows the value now that people are seeing in downloading and using the app. So we've got active users of over 325,000. So those are people that come back again and again, and are actively engaging and using in the app. And it continues to grow. We've had 4.3 million prescriptions, repeat prescription orders, 240,000 GP appointments have been booked through the app. Believe it or not, I mean, this is a phenomenal number, but 850,000 waiting list notifications. That actually is quite scary. It's great that this is happening, but it's quite scary when you see the numbers of waiting list notifications. And 780,000 hospital appointment notifications have been sent using the app. So it is now starting to become that thing that we wanted it to be, that kind of usable kind of partner in your healthcare journey. So that's those numbers are the numbers. They don't actually show the value. So that's something we really want to get into now with the app, is showing the value, what that actually means to patients. We've established a new patient-facing digital services advisory group, which is quite a long title, but it actually does what it says on the tin. So this is to strengthen the governance we have around patient. So not just the app, this is patient-facing applications across the Welsh NHS. We've got representation on that group from primary care, secondary care, P&I, Welsh Government, Directors Digital, WAST, LICE. So it's a very comprehensive and knowledgeable group, and it's got the opportunity to shape that patient-facing digital offering across Wales. And the primary aim is to reduce the burden and confusion for patients, which is a constant feedback that we get. We don't know where to go. We don't know how to get this information. You might say there's a single front door. We think there's about 5,000 front doors. So how do we make that? How do we simplify that NHS offering? And also, how do we limit that duplication and ensure we're getting the most value for money in our patient-facing tools? So, really pleased that group has been established and it's met, and it's had very strong engagement. We've still got some challenges in the app world. So the funding has been agreed, which is great. That was really welcome news that we had recently. However, recruitment restrictions are going to impact our ability. So to give that some flavour, what we can afford to pay for with a third party to support us, we could probably run 4 teams internally. So that gives you some kind of understanding of the scope of our ability to deliver, while we don't have the people in-house to do that work. And of course, we want to do more. We want to deliver more for patients. So that is a circle we're trying to square, and we're still coming through looking at what the impact is of not just that recruitment, the recruitment situation, but also the fact that we've had funding quite late in the day. So what impact would that have, and what mitigations can we put in place? We've done a lot of work in getting some really strong user research together, and stakeholder engagement. We've met with all the health boards recently to go through their priority list and their roadmaps. And we've got some very strong priorities coming through. Waiting list referral enhancements is something that comes to the top of the list. Digital document services, expanded GP functionality is something that comes up all the time. There is already a growing list of roadmap, and that's something we'd want to bring back. We're looking to put that into a now, next, and future, so it becomes very clear when you can start expecting some of these things to start appearing. And it would be good to bring that back at some point in the future. Just 2 other things I was going to touch on. One is the design system that we're developing. Not everyone gets excited about this. I get really excited about this because it is a digital development necessity, having a design system. And the one we're developing in DHCW is really comprehensive. So the idea is we drive consistency and efficiency across digital products. That look and feel is not just as important for people, for users, but actually it means we're compliant with accessibility rules and security rules and things like that. And it also means that we get to develop, when we develop digital products, we have a set of pre-designed, pre-tested, reusable, and most importantly, compliant components that no longer have to be built from scratch. They can just be downloaded and used and fit into whatever you're going to design. The speed that will add to our design and delivery capability, once that's embedded, will be immense. You can call it, we're already having people being able to do things much, much quicker than they were able to do them before because they're not doing them from scratch. So we've got some key milestones now. So completion of coding those components through the summer. And then a lot more user testing of the components to make sure they're absolutely right. And then launching the design system on a website and a component portal so that we can share that within DHCW, but also we can share that across NHS Wales. We were only literally yesterday talking to WAST about how they could start consuming the components that are being developed in this way. So it has much more utility wider than just inside the DHCW. And then the last thing I was going to touch on was vaccines. So there's a few exciting things have happened in the vaccine space recently. So firstly, in June, the vaccine service became the first NHS Wales service to complete a Welsh Government digital service assessment. So service assessments are commonplace in England and have been around in the public sector probably for about 15 years or so now. So adopting them in Wales makes absolutely good sense. And it's a way to assure that we're delivering quality digital products. This is something, as you're probably aware, has come through quite strongly in our escalation work. We're being asked about how do you assure quality? And it can't always be done through user feedback and research. Sometimes it has to be done by being assessed, and being assessed in a way that is very focused on the digital product itself. And I guess the best way to describe it is like putting your digital product through an MOT, as you do with a car. It kicks the tires and it tests the things that make a digital product important. So there are a set of clear objectives. For us, they are the digital service standards for Wales. That's the primary thing that we're tested against. And that has a number of components that cover things like user-centered design, that meets user needs, making the best technical choices. So are you using the best things to deliver your tools? Are you making the right choices on your components, on your programming language, all of those things? Are you developing it ethically? So you're taking the sort of ethical considerations into account and with privacy and security embedded from the start. So you're not having actually to go back and rework it because it's not cyber secure, it's not compliant. And of course, developing in English and Welsh. So all of our designs are designed at the start with English and Welsh, not the thing that we used to have, which was you design it in English and then you have to then go back and re-engineer into Welsh. That doesn't deliver a good outcome generally because it wasn't designed with Welsh from the start. So we get very, very much marked on that in the digital service standard. So the assessment highlighted for the vaccine team, purposeful bilingual design, strong service ownership, effective collaboration across organisations, strong user-centred delivery, and a clear focus on outcomes for Wales. So the team are really thrilled with what's come back from that assessment, especially as it was the first one. And they were really scared. It was quite scary, being put up in front of a group of specialists in the digital world who are going to question you about your product. And you have to respond and provide the evidence for them. But it's given us some really clear recommendations of how to improve in the future, which we will do. But with 14 million vaccinations have happened across Wales since we've had this system. And that's across all 7 health boards. So it is really encouraging to receive this independent assessment that the service is delivering significant value to Wales. For us, it was a real, it was difficult but the process is absolutely worth going through. And I think we'll talk in the future about how we want to do more of this. Sam Lloyd and myself have been talking a little bit about how we want to bring this much quicker across our products and services in DHCW. And I think finally, I just want to touch on another little last minute that we were asked to do. You may have seen in the news over recent months that meningitis has been on the rise across the UK. And of course, Wales wants to make sure that we are in a good position to support people with that. So we were asked to to develop ways to run the meningococcal B or Men-B vaccination programme out across Wales. From being made aware of the ask to being live, enabling the delivery on the ground across Wales took 20 working days. And so that just shows the investment we've been made, that has been made in building the system to be scalable, adaptable. And it's beginning to show that real value, because it means we now can do what we always wanted, what our real vision was, which was give us a vaccine and we can plug it in and you can run with it. And that actually, I think Men-B showed us the ability to do that. And especially when you think about the at-risk population here, are quite often those young adults getting ready to go to university for the first time. And so how do we capture those people, get that vaccination in their arm before they go away in September? So we have this summer window effectively to do that. And so far 10,000 jabs have been given into that population. So, it really absolutely, worthwhile thing to do. And I think it has showed us that working in this much more flexible way that we've developed the system works. We're also doing a lot of work on school age vaccinations at the moment. That was in our remit letter, to the point now where we're doing our user research with parents. What is it that you need? One of the things that comes back again and again is e-consent. How do I say yes to a vaccination when actually what I'm getting from schools every day is a flood now of WhatsApp messages and don't forget football kit. Don't forget we're going to St. Fagans next week. Don't forget you're doing this. Oh, by the way, your child's having a vaccination. Is that okay? So, how do we make sure that comes to the top of the list? How do we make sure that patients are aware of it? And we've actually got 90 parents now as part of a user group who are giving us feedback on school age immunisations. Don't think anything like that's quite been done before, but we have a reference group of 90 parents now that we're talking to all the time about this, and who are really happy to share their experiences. So that's great. That's really good. And I think the last thing I'm going to leave with, because AI is obviously flavour of the month everywhere, is the team has been working on some AI tools to support them actually in-house. So these aren't things for outside. But they've developed a tool to start moving work around in the database, and just literally hot off the press being told that the AI-powered database migration tool that they've developed has now saved 3,000 hours of manual effort. So we're seeing this across the organization now, where we're able to consume AI in a way that is freeing up. I mean, that time will now be freed up for people to do other much more meaningful work. It's the whole premise of AI was to take the robot out of the person. And I think that's absolutely what we're showing, being able to do that. And we, working with all of the teams, actually, there aren't any teams not looking at AI to help them, do better work and do more work in a more meaningful way. So I think that's just shows, the power of what you can do. And that's just a small little thing that we can do to take some pain away. So they were the 4 things that I was going to focus on. I said I wasn't going to talk for long, and I did. But happy to take any questions.
Okay, it's too much good stuff going on, Sam. Thank you for that summary. Rydian.
Thanks, Sam. And look, it's really welcome to hear all the news on how we're supporting the primary care workforce and the community workforce and patient empowerment to manage health conditions, which is the ambition, isn't it? So that's excellent. A couple of questions from me. You mentioned DocMan, Sam. We've always had issues relating to who pays for it, how it works. Is the national programme providing DocMan for everyone, or is it an assumption that the primary care providers have to have it? Because I know not all of them have it. So that was my one on the eyes, and then I've got one on the app.
Okay, I could do the first DocMan one. So I'm not sure who is currently paying for it, but I can check. But I know that only, I believe, of the last, so we've been rolling this out quite quickly. I believe there are only 19 practices now that don't have access to DocMan. Excellent. So okay. I will check that.
You're absolutely right to highlight the workflow. I've got to get the information into the record visible to those who need to see it. Great.
Absolutely.
Right, this is one you'd expect on the app. A couple of things. First of all, just to highlight the website, our organisation website, and the ability to provide feedback. So that's really useful. You're doing some survey feedback. I think the appointments, in light of the presentation we just did about planned care program, patients really want to know, have I been referred, and when my appointment is. So that's a definite win. The next thing, of course, they want to know is, am I on the waiting list, and what my test results are. Any sort of thing you can share about when we may be able to do that, because we know colleagues over the people who are receiving care over the border find that very useful, don't they?
They are, and those are both things that are on the list. What I'm aiming to do is to bring, obviously we'll come to our execs first, but to bring that now, next, and future development roadmap. Obviously we'll bring that to the board as well, but they're on the list. At the moment, we are just looking at our dependencies. Some of these things are dependent, obviously, on health board engagement as well. So that's why those meetings with the health boards are so important, because what we really want to do is make sure that that's an equitable offer across Wales. So getting everything in line is really important for us to be able to do that. Right, I can't give you a date, but I will tell you they are absolutely on the list, and they're high on the list. Test results can't really get any higher because Helen talks about it every day. Because it is absolutely the right thing to do. We know that is what people really want from us.
Just to come back on that then, are you and your team limited in terms of the capacity and the funding to deliver, the timely functionality?
So funding we've just had agreed, but obviously it's well into the next quarter. But so that's not ideal. And it's something we need to make sure that doesn't happen again next year. I think, not being caught up in the DPIF funding issue would be great. I mean, the app is going to stay. It should be core functionality, and so we need to look at how we look at funding that in the future. But the capacity issue will be that we had a plan to bring in, as I said, 4 teams. We only have one of those 4 teams in house. The rest we will have to look for a partner to work with, which will limit how much we can get done. So absolutely, that is a consideration. So we are going to have to cut our cloth accordingly this year. Hopefully there is a case we can make around those specialist skills in the development space that we want, but there is obviously going to be a process to go through if we were to want to bring in any new roles, and it won't be a quick process because recruitment will take time anyway. So we're going to limit it. So that's why we're doing that piece of work now, to understand what the imperatives are that we absolutely must deliver this year and what we can raise up the list.
Okay, thanks. We are running over on time, so I'll ask two Chris's with questions to be brief and for you, Sam, to be as brief as you can with your answer. Chris Darling.
Thanks, David. Yeah, just a question on community by design. It is really exciting and there's lots of momentum around it. I don't believe there's any investment or funding linked to it. So it's just a question on, is there a risk, Sam, about overcommitting and under-delivering? Because there will be lots, as you've said, that will be wanted, needed from a digital perspective in that space. So it's just a quick question on risks for us to consider.
So you're right. Quick answer: no, there isn't any central funding. However, there was a very clear line from the Chief Medical Officer that there are lots of programs delivering good work in this space already, and we need to understand where some of the capability and capacity has been delivered elsewhere that can support community by design. So we've actually in DHCW, we've done a piece of work to look at that, to map all of the work that's going on across DHCW that actually would lend itself to deliver something for community by design that is either already funded or already on our roadmap. So for instance, in the connecting care space, whilst we're not delivering those products in the connecting care space, but we obviously set up the program and petition for the money to do that. Those EHRs that are being delivered now across community and mental health, they'll be fundamental to making this happen. So there is something there. Obviously, the integrated care record would be, again, fundamental driver for community by design. We didn't get funding for it, but we have a plan of how we can maybe repurpose and broach that in a different way. So I'd say not having that funding pot is a challenge. Will it stop us delivering some of the things? I don't think so, but we may have to cut our cloth accordingly, and we absolutely are not overpromising, because at the moment there isn't a promise to make, because I think they are still working through what needs to be done. When it becomes more clear, which I think it will through the next couple of months, we'll need to understand how we manage that, which is why Helen requested that we look at what that capacity might mean, and also set up a steering group in DHCW so we can make sure that we are putting what we can afford to put in the right way into the best spaces possible. We can't just say we're here for everything, because we won't be able to do that.
Okay, thank you, Sam. And one last question from Chris, and then we'll need to take a break. Chris.
Yeah. Thank you, David, and thanks, Sam. I just wanted to pick up on your point around service assessments. I was just interested in how could this approach help to improve our decision making regarding investments in digital and our ability to demonstrate value for money.
Oh, I've got to be quick, but so the first one, the way you would normally structure a service assessment is after discovery, then alpha, then beta. So actually you would have some funding allowed to do your discovery, and at that point you go to a service assessment that may say there's not enough evidence here that this should proceed, this is not a sensible way forward, and you will not derive the value from taking this forward. Go back to the drawing board effectively and come back with something else. And then at the next stage, at the alpha stage, before it goes to beta and live, generally post alphas, as you get into that beta phase, is where you would have the biggest chunk of money going in. That would be where the big cost is. And again, it makes you it makes you evidence the value that this would bring. So I actually think it gives us the opportunity for more control. I would love to see funding linked to service assessments, as it is in England. I think that is absolutely a sensible way to go. But I don't know that Welsh Government are deciding to go that far. I think there is something that we could do when we're looking at how we develop our service assessments inside HCW, because I suspect we'll go a little bit sooner. Welsh Government is still going through their pilot phase on this. We'd like to do this and link it with our move into product and agile. So we'd like to go actually ahead a little bit. One of the things we could do is to add into that service assessment a financial element and a value for money element. It would be really good to actually, on that assessment panel, to have someone from the finance team who says, well, have you spent the money well? I've always thought that was something that was missing from service assessments. Doesn't mean we can't add that in. Prove the value as well as the quality.
Yeah, thank you, Sam. Yeah, I'd be happy to pick that up and work with you on that moving forward as well. Sounds like a good opportunity.
Great. Okay. Thank you for that, Sam. Some really good highlights in there. Always great to hear some good news. We're now due to take a short break of 10 minutes-ish. We'll run over a little bit. So can I suggest we resume at 11:35, which is about 8 minutes or so? Thank you. And can I remind everybody to turn their cameras off and microphones off during the break? Okay, welcome back, everyone. We're now going to move to, excuse me, item 5.2 on our agenda, which is the Strategic Operations Report. And I'm going to hand over to Sam Lloyd for this item.
Thank you, Chair. I'm really pleased to have the opportunity to be able to talk to the board about some of the work that's going on across operations. And as you'll see from the report that I submitted, there's quite a bit that's underway at the moment. I'm not going to talk through all of it. As Sam said, I'm going to try and be brief, and I'm going to try and pick out some of the key points just that I would like to bring to the board's attention. I think it's important to start by reflecting on the scale of what we do in operations. It is a really big function, and we provide a broad range of services. So I generally try and describe it as a twofold set of responsibilities. So we have the suite of products which are consumed by clinicians and other professionals in the secondary care space, and that's split into two. So we have the single record suite of products, which includes some of our really big secondary care services like the patient administration service, the clinical portal, the nursing care record, and so on. And we're providing specialist services from those products into areas such as oncology, palliative care, diabetes, to the nursing community, etc. The second pillar of services is the medicines and diagnostics. And again, there are some really foundational components in there, such as laboratory information management systems, radiology systems, without which hospitals are really unable to function. So really critical services delivered in that space, along with point of care testing and some other diagnostics capabilities. And then underpinning those services and also underpinning the rest of DHCW and to some extent the rest of NHS Wales are a range of cross-cutting technology capabilities and services. So that includes core platforms and APIs. So all of the systems and services that we operate, and many across the wider system, are exchanging data through platforms operated by that function, including our integration and API services. We've got a cybersecurity function, which is really looking to drive improved cyber posture across the whole of NHS Wales and obviously manage the threat profile that we're now facing, and to manage the cybersecurity of our own suite of products as well. We have a cloud and infrastructure capability, which manages data centers, networking, cloud capabilities, and also provides a managed desktop service to over 14,000 users across Wales. We have enterprise service management, which ensures that our services are managed and operated to internationally recognized ITIL standards. And then we have a digital delivery capability, which is really crucial in knitting all of that together and helping us to steer it all in the same direction. So we've identified a number of key outcomes that we're working on across operations, and these really complement and sit alongside the 12 overarching big things to get done that we've defined for DHCW. So these are really aligned closely to those deliverables. As I said, I'm not going to go through all of them, but to pick out some of the key ones that I think are really going to be transformational. Our cloud migration program. So this is, we now have DPIF funding to continue with this work, which is obviously really important to us being able to make progress with it. This is a strategic undertaking because it's not just about moving stuff from an on-prem data center to a cloud environment. It's about transforming the way that we work. Modern cloud native applications are more performant, more available, more secure than their data center predecessors. So moving in that direction is really important for DHCW. And it's a key part of some of the value conversations that we were having earlier. The ability to build products in cloud native way means that we will be able to build them more quickly, deploy faster, and therefore deliver value at greater pace to our stakeholders and consumers. We're well underway with cloud enablement works now. So we've got the core underpinning platforms built. We've got the suppliers onboarded who are going to be working with us. We're doing detailed wave planning now. We're specifically looking at migrating WPAS as well, which is obviously one of our biggest platforms that we manage nationally. We've currently got 7 instances of that across the system. So there are significant opportunities alongside the regional working conversation that we were having earlier in the context of planned care to look at whether or not we can start to standardize the way in which PAS is used. There's some significant cost avoidance opportunities by doing that as well. There's some license implications to not moving to cloud, not moving WPAS to cloud, which we're making sure that we take forward. So there's some significant cost savings for the system. There's also a lot of work that we're doing within the team and across DHCW to upskill our people to enable them to work in a cloud native way. This is not just about technology, it's very much about ways of working. And a big part of the program is directed towards providing training and operating model transformation for our people. The next thing from the report I wanted to highlight is the work that we're doing on strengthening the cyber posture across NHS Wales. And we've talked before in this forum and in others about the external threat situation and how geopolitical events have changed that over in recent months and years, and also how we've seen a significant increase in cyber attacks against healthcare providers, including those in England, Scotland, and in Ireland. So the threat that we face is real. NHS Wales is a closely connected and tightly coupled organisation, so it's important that we're managing our cyber posture as one. So there's some really important work that we're doing to establish national cyber governance, to make sure that we've got a forum where conversations can be had at a strategic level about cyber security, establishing some national KPIs so that we've got a consistent way of measuring our posture across the whole of the system. And then that will naturally lend itself to, once we've established that baseline, what are the things that we need to do in order to improve it, and how do we coordinate that activity strategically across the system? We now have a single security information and event management platform that's used across Wales. That's ingesting many billions of records every month, and that gives us a central point of view of all of the activity, all of the security activity that's going on across the system. And we're working closely with our colleagues across the health boards to target some specific areas of activity that need to be done to uplift the cyber posture. I think NHS Wales working together as one on cyber there's a real opportunity to transform our posture and the way in which we're going about this. So that work is well underway, and I'm really pleased to say that we're getting some really good traction with our stakeholders on that now. The next one I wanted to highlight is the maximising the return on investment from the Microsoft 365 enterprise agreement. So we approved that agreement at the board fairly recently. So there was a large piece of work that was done, again, nationally with close collaboration across the system to put in place a new enterprise agreement for the Microsoft 365 suite of products. These are the products that underpin our ability to work day to day. When we're having meetings, when we're collaborating with colleagues, when we're sending emails, all of that is done on the 365 platform, but it also provides a load of other capabilities around security and device management and so on. So it's really foundational to the way that we work. We had a really good outcome from that agreement. As we previously discussed, we were able to avoid a very significant cost increase, which we were initially facing. So that was a really successful piece of work. And we're now going full tilt at driving the value out of the new contract. And the first way in which we're doing that is by rolling out Copilot chat across the whole of NHS Wales. So this is a version of the Copilot AI productivity tool, which is built into the platform. So it comes with the licensing, it's not an additional cost. So we've been working with Microsoft to drive an adoption program across the system. And we've now got 35,000 users across Wales using Copilot chat daily, or sorry, monthly, 35,000 monthly users. And we've trained 5,500 people on that platform. So it's been a significant effort, and it's really starting to deliver some significant rewards. We've done some work to try and understand the efficiency gains that we're getting from people using this, and the numbers are really encouraging. Most people are saying that they're saving up to an hour when they're using Copilot. So we can extrapolate those numbers and come up with some pretty big efficiency savings. We're kind of resisting doing that at the moment because there's more work we need to do to validate it. But I think, you know, we are really starting to gain quite a solid body of evidence now that this is a tool that will increase and is increasing productivity across the system. So we heard from Ridian and Alex earlier on a lot of the work that's being done in the planned care world, so I won't go over that again. A lot of that work is being delivered through teams in operations. We're also working on urgent and emergency care, so closely with the 6 Goals programme in NHS P&I to support the rest of NHS Wales in adopting the Welsh Emergency Care data set. Because we know that the quality of data that is gathered within EDs is not great. It's a lot of it's on paper. It makes it very difficult for policy leads to really understand the kinds of situations that are bringing people into EDs, and therefore the kinds of interventions that could be taken that might help to reduce that or to manage capacity better across the system. So the emergency care data set is designed to help improve the quality of data. So we're building a new urgent and emergency care app, which is a new, as I say, it's a new cloud native product. We're working at the moment with Powys on user acceptance testing for that, and it's our intention to support the deployment of that to other health boards who want to take it in the coming months. So some quite big opportunities there, and it's really piloting some of the new ways of working that we've been talking about as well, in terms of cloud native and modern software engineering practices and so on. And then the last one that I just wanted to highlight is around the, and Sam touched on this in her update as well, is ways of working. So there's a big push across the whole of DHCW to adopt modern, agile ways of working, and we're certainly going after that in operations as well. We're also looking at AI-infused engineering, as we're calling it. So the potential of AI to change the way that software developers work and change the way that software itself is built and developed and designed and delivered is really quite significant. So we're pulling together a pilot where we're going to be provisioning devices and software and tooling to a group of people to help them get up to speed with this new way of working and prove the concept in a couple of specific contexts. So we've got some candidates for early development in this new way, which we'll be looking to take forward in the coming months. So that's some of the activity that's underway at the moment. There's a number of other areas of focus as well, which are probably equally significant in their own way. So, for example, we're looking at what is the future of the single record suite of products. We know that those products have been serving NHS Wales well for many years. We know that there's potentially ambitions to adopt electronic health records or electronic patient records across Wales. Those are going to take some time to implement. So in the period, in the interim, we need to continue to develop our suite of products, and we need to understand how they can best be used to help modernise and transform care and to deliver the wider government ambitions around that. So we really want to start some structured work on service design and stakeholder engagement to help us understand what is the next generation of single record capabilities. Regional working we touched on earlier, but there's a really big opportunity in that space, I think, to address some of the long-standing issues that we face around inconsistency of working practice across organizations, inconsistency of data and record keeping and so on. So some of those will become pressing as we need to start, enabling regional working. We're really closely involved in that. I mentioned earlier that we're looking to improve our reporting of delivery and value. We're establishing teams who will be working on the ground with consumers of our products to actually help document and really baseline where efficiencies are being delivered and to what extent they're being delivered, and then to report that back through the product reporting, and that will go through our normal reporting routes. And then we're doing a lot of work also within ops. Just the last one to highlight is to support DHCW's savings and efficiency objectives. We've delivered some very significant efficiency savings in recent years through operations, and that's both through staffing efficiencies and also through contract management and other things that we've been doing. So we've made a pretty significant contribution, I think, in that regard. So just wanted to call out those few things. It's a snapshot of the huge amount of work that's going on across operations. I'm really proud of what we do. I want to use this opportunity to say thank you to my team and to teams across operations for the amazing stuff that they're doing day in, day out. So thank you, and happy to take any questions.
Great, thanks, Sam. Anybody got any questions for Sam on his update? Helen.
It's probably more a reflection than a question, in that it's really good to hear kind of that snapshot and to actually share the amount of work that is going on that is kind of under the radar, if you like. It's not necessarily talked about. We do spend a lot of time talking about the new stuff and the major projects and programs. So I think it's really helpful to understand not just the other work, but also the work that goes on to actually facilitate from Operations Directorate, and similarly with Sam's update there, Sam Hall's update earlier, there's a lot that's going on, isn't there, that isn't necessarily as visible as some of the major program stuff that we talk about. I think that there's been, both papers reflect a significant shift that we're making in the organisation in terms of our ways of working, in terms of the way that we engage with the wider NHS and our stakeholders. And I I think there's a different, it feels like there's a different kind of tempo to some of that now than perhaps we've had previously. And I think the investment in the in each of the directorates and the structures and the change that's been going on, we're now starting to feel the impact of that then, I think, and that can only grow really. So yeah, it was just really good to hear all of that information. Thank you both.
Thanks, Helen. I'd echo those comments as well. Chris Morton.
Yeah, thanks. Not a question again, but just a reflection as well. And Sam talked about there that the new Microsoft agreement, which we've gone live with this month, which was a tremendous amount of effort. So again, thanks to all that was involved with that. But my reflection was actually I attended, I had NHS Wales Equalities Week recently, and I attended one of the sessions there about how Copilot can support neurodivergent colleagues in the workplace. So actually, as part of one of the wider benefits of this, and I know that, again, Sam's team has been working to roll out the Copilot chat, I actually think it's important that we don't forget some of the wider social value impact that this technology can have and how it actually contributes to the EDI agenda as well. So I just wanted to note that.
Yeah.
Thank you.
Yeah, good. Well, point well made, Chris. Thank you. Sam, can't see any more hands. I've just had one question myself, which was you mentioned about the need for a pan NHS Wales body to coordinate our activities around cybersecurity. I know you've been making progress in that direction. Have we got to the point where that's now actually formed and meeting, or is it still work in progress?
I think we can say it is, David. Yeah. So we were instructed really clearly from the former cabinet minister at our public accountability meeting to proceed with that work. So we are doing so, and we're evolving the CSIRO and Caldecott Guardians Forum into the governance group, which will oversee strategic cyber operations matters. Yeah.
Great. Excellent. That's good to hear. Thank you. Right. I can't see any more questions. So we're going to move on to item 5.3 on our agenda, which is our strategy assurance group report. And for this, I'm going to go to Michelle Sell.
Thank you, Chair. I'm going to give a brief update from our strategy assurance group and call out some key points from the report. So primary objective for the group is obviously to oversee the delivery of our DHCW organisational strategy. We also have a number of what we're now labelling as sub-strategies to avoid the confusion, which are in particular areas of the organisation. And just by way of context, the group have been focused on trying to streamline and make sure we're really clear and consistent in terms of the way that we are developing and operating our strategies. And there's been good progress on that over the last period. We've got a playbook. I think we're much more aligned now in terms of how we're taking this forward. So that's really helpful to see. We will be bringing a substantive update in terms of where we are on the overall strategy, and you'll note we've got the performance report, I think, coming up a bit later on the agenda, where you can see progress against strategic objectives against each of our missions. So we've got that ongoing oversight and management. But in terms of the way we are managing strategies through the organisation, we've got two categories really. So any net new strategies that I would anticipate go through an internal consultation process through our management board and to the board. So the board itself will consider those and will be discussed and approved at this level. Where we've got sub-strategies that are going through a refresh or an update, which we do, so these are live documents, so they would be refreshed during their term. Then those still go through consultation, so there's the opportunity for internal comment, and they're approved by the management board. So there are a couple in the report that are identified that have gone through that process. So just for the awareness of board members. So the first of those around Welsh language strategy. I'm sure you've discussed that a lot at the board level. So that's been updated, not just for the kind of statutory requirements for us as an organisation in NHS Wales, but obviously our ambition, which is really to embed the Welsh language in everything we do. It's really pleasing. Sam mentioned we're now developing with Welsh in mind, and that's really important. So there are other aspects about raising capability within our own workforce, which helps us then to kind of spread that in terms of our developments. So some key updates in that strategy. The business continuity strategy. That one actually lives in my area. Really happy with that one. So that's about how our resilience as a business or as an organisation, how we ensure that we continue to operate effectively if there are particular challenges or issues arising. So a recent situation would be the severe hot weather, for example. So I'm pleased we reviewed and reported that didn't have a detrimental impact. We put measures in place to address that as an organisation, but obviously it's really key that we've got an appropriate strategy and plan in the event that such an incident does happen. So that one has been refreshed and approved, and our environmental strategy. So also really key for us as a public sector body in Wales. So those have been approved, and they're stated there for the information of the board. Also, we've set out there in the next sort of 6 months, where's the focus of the group. We're particularly planning to look at commercial and social value. Again, another key area for us as a public body. Cloud, we have a cloud strategy. So that would be in the kind of review category. And then we've got 2 strategies that are currently in consultation around communications as an organisation and our engagement strategy. So I was going to leave it there, David, but I'm perfectly happy to take any questions if anyone has any.
Okay, thank you for being brief, Michelle. Can I just check, see if anybody's got any questions on Michelle's update? Marion.
Diolch, Cadeirydd. A gai jyst dweud gymaint sy'n ni'n croesawu'r strategaeth ar gyfer yr iaith Gymraeg. Mi ddaru ni gymeradwyo'r ddogfen yma yn y pwyllgor archwilio yn gynharach y mis yma. Ac oedd na groeso brwd i'r ffaith bod ni mor rhagweithiol i weld cynnydd yn y defnydd o'r iaith Gymraeg a chefnogi staff hefyd i gynyddu'r defnydd o'r iaith Gymraeg. Felly mae'n gyfnod cyffroes o ran yr iaith dwi'n credu o fewn y sefydliad ac braf gallu adrodd hwnnw nôl i'r bwrdd. Diolch yn fawr.
Thank you, Marion. Anybody else got any questions for Michelle? Her update was quite precise, and thank you for being saving a little bit of time because we were overrunning, Michelle. So my thanks for that. We've been asked to note this report, so thanks, Michelle, and we'll move on to section 6 of our agenda. And the first item there is 6.1, which is escalation status, and for that I'm going to go to Chris Darling.
Diolch, David. Yeah, I'm just going to run through the update paper within the documentation, which relates primarily to the activity that's taken place since our move from level 3 enhanced monitoring to level 4 targeted intervention, and that change took place in April 2026. We've been working closely with Welsh Government and the NHS Performance and Improvement Unit to understand the changes and to respond to the change and escalation status. So just a couple of things that we've done over the last few months since the last board meeting. So we've met with NHS P&I 3 times actually since our last board meeting at the end of May, in June, and then last week in July. And that's been very much focused on shaping and understanding the intervention element of the escalation and the support being provided. We had one escalation board since our last meeting on the 9th of June, and that was very much around holding the organisation to account for the concern areas set out within the escalation. I know, David, yourself and Helen have met with P&I as well to consider the principles document since our last board meeting on the 16th of June. Internally, we've had a board development session focused on escalation, the changes in the escalation status. We had a session at one of our quarterly senior leadership days just to understand what it means to us as an organisation and ensure staff are involved in shaping the response to escalation. We're also meeting now on a weekly basis as an exec team solely on escalation to review the plan and our response to the plan. So just going to quickly run through some key areas. The targeted intervention level 4 escalation framework has formally been agreed by DHCW with Welsh Government since the last meeting. A draft of the escalation framework was shared for any comments. We reviewed at the board development session at the end of June and has since gone back to government and confirmed that framework is now the framework in place to monitor escalation. From an NHS performance and improvement intervention perspective, as I said, we have met with them a number of times. We're also working with them closely in the background on an ongoing basis around supporting the work that they need to do. They are taking a two-phased approach as directed by Welsh Government. So phase one being an evaluative review, and that's based on the core principles document. This work will then inform phase two, which is the delivery phase, where we expect an external independent advisor to be commissioned by NHS Wales P&I to support the phase two work. In terms of the phase one evaluative review, we've provided evidence to performance and improvement to assess the current position against the core principle areas. We've also provided a number of independent reports that have taken place over the last 3 years or so. And just to name a couple of those, there was an independent review and report that the board commissioned back in 2022 into programme governance arrangements. So we've provided that. That was published in March 2023 by an independent governance advisor. Welsh Government commissioned a review into the DDAT, the Digital Data and Technology Governance Review, and that published their report in December 24. We shared that with the performance and improvement team. We've also shared a number of other reports, including the work Technology did last year to support an assessment of DHCW as part of the enhanced monitoring arrangements when we first went into escalation last year. And we shared some of the outputs from the digital blueprint work that Helen mentioned earlier. So they've got the independent reviews and they're working through those along with other evidence that the organisation have provided. Just to expand on the escalation board on the 9th of June, there was a big emphasis on DHCW stepping into a system leadership space to transform health and care through digital. So some of the work we've done and reflections since that, obviously we had a number of discussions at the board development day. We've since taken some of the areas that we identified as areas where we could potentially step into a system leadership space and approach things differently. We've defined what we believe system leadership means because we appreciate it's potentially a subjective term. And we've also identified, as set out in the report, a number of areas where we're planning to change the approach in terms of system leadership. So that's something we're proactively working on. In terms of the enhanced monitoring phase two plan that was approved through the Portfolio Delivery Committee, that's going back to the committee next week. So I'm not going to cover that because we'll cover progress on that plan in detail when we get to it next week. And then just finally to say, in the report, it does mention the digital blueprint work. It's not directly linked to the escalation, but we know that ambiguity of roles and responsibilities have been a key theme that has come up throughout escalation. And I know a key part of that work is to look to address and get clarity on roles and responsibilities. So we're keeping it very closely aligned to the escalation work as we work through the outcomes of the digital blueprint and ways of working. Those were the key areas that I wanted to highlight, David, and happy to take any questions.
Right, thank you for that summary, Chris. I'll pause for a second, see if anybody's got any questions. Marion.
Diolch yn fawr, Gadeirydd, a diolch yn fawr, Chris, am yr cyflwyniad manwl yna yn amlinellu popeth sydd wedi digwydd ers i ni gyfarfod diwethaf fel bwrdd. Mae'n nghwestiwn i'n ymwneud yn benodol am rôl P&I ac fe gyfeirio chi at y ddau ran o safbwynt i cyfraniad nhw, sef yr adolygiad gwerthusiad i ddechrau, ac yn ail, penodiad arfaethedig ymgynghorydd annibynnol. Fedrwch chi egluro pa bryd ni'n debygol o weld yr ymgynghorydd annibynnol na'n cael ei gomisiynu ac yn dechrau'r gwaith o gefnogi'n sefydliad ni?
Diolch, Marion. Yeah, I think we're probably slightly behind where P&I wanted to be in terms of the review process and therefore having some independent support brought in. But I think that's been deliberate. I think the level of information we've been able to provide has given them a more comprehensive picture during the phase one element of the approach. So they're working on what they had termed a position statement, but I think it might also be termed as a baseline position. Once they've got that confirmed and agreed, they will then look to commission, and there will be an element of availability and making sure they can get appropriate input at the right time. So it's probably difficult to say exactly when that will be, but we are meeting with them again in September, early September, and I suspect we'll have a clear update at that point in terms of where we'll be in terms of any independent input, because I think the baseline position will be known and will be clear on the areas they want to get independent input to. But I'll check if Helen or any other colleagues want to expand on any of that.
If it's okay, I'll come in, Chair.
Yep.
Yeah, no, I completely agree. I think that there's, I think helpfully, Welsh Government and P&I want to ensure that they step through this process. We are a very different organisation to the Health Board, and I think that requires kind of a change of approach potentially, and some wider consideration, I think. And I think it's really helpful that, in fairness to colleagues, they're acknowledging that and trying to work that through with us. So I think it's, we will get that independent assessment happening, but it will build on the work that P&I are doing at the moment. I think it's been really helpful, the conversations that we've been having around these position statements or baselining, because what keeps coming through the conversations that we're having is what we're after is clarity, and I think that clarity around role and responsibility, and then the visibility of the wider work that we do as an organisation, the 80% that isn't major programmes, I think is will prove really beneficial, I think, in terms of raising that understanding of the breadth and depth of the work that we do. So so far they've been challenging but helpful conversations would be my reflection on them.
Great,
Okay.
thank you.
Thanks, Helen, and thanks for that update, Chris. Just a couple of points from me, if I may. I just checking my understanding. I think from what you said in answer to Marion's questions, the meeting in early September is likely to be the end of the evaluation phase and then the start of the next phase. Can I just check that I've understood that correctly?
I think that's where we expect to be, David. Yes.
Yeah. Okay. That's great. And Helen, you've made a really good point about the blueprint and it addressing some of the issues that we've had. Can I just check what's the timeline for completion of the blueprint work?
So there's more work to do over the next couple of months, but I think by sort of early autumn we will have finalized approach. So we've got pretty complete views now, the ways of working, the action plan, the operating model. So there's been a lot of feedback on that. So for the technology colleagues, they're now kind of running through, how does funding flow through a new model? What examples can we run through them? What does the governance need to look like that actually delivers those ways of working? So it's working through those now to bring this to life, so that we can actually look at it through the lens of real examples, real worked examples that, if we'd had this approach in place, would things have been better in some of the challenged areas that we've got at a system level? Yeah. So I would expect sort of in the next, by the end of this quarter, we'll be really clear on a way forward from that. And that aligns really nicely with the work on the strategy the Welsh Government have commissioned.
Okay. That's great. Thanks for that update, Helen and Chris. Board is being asked to receive this report for assurance. So there's no further questions. So many thanks for that update, Chris. We'll now move to item 6.2 on our agenda, which is the People and Culture Report. And for this, I'm going to go to Sam Morgan.
Thank you, Chair. Prynawn dda pawb. Diolch, Chair. I'll take the People and Culture report as read in the interest of time, as my colleagues have previously. But I did want to focus my comments on some of the points most relevant to board assurance today, if I may, Chair. So the message is that the work is helping us to translate our ambition set out in the People strategy, which has been to board previously. And we're doing this in a practical way, building the skills, capability and the confidence our people need to deliver on our priorities that you've heard lots about today in the discussion. And what we really want to do is to equip our workforce with the skills and capabilities to make a really meaningful difference to patient outcomes and the citizens of Wales. So the work described in the paper is a key component of that delivery, showing how we're moving from that strategic ambition set out in the People strategy to actually implementing a strategic workforce and capability planning framework and a future skills model and more of an evidence-based approach to recruitment, development, talent and workforce investment. In particular, the paper that you will have read describes the progress being made in understanding our digital workforce, which, as you will know, makes up 67% of our workforce. And I'm really, really pleased to report that within that profession, 93% of the roles have now been aligned to the GDAD Government Data and Digital Professional Framework. So this really takes us beyond headcount and structures, and what this mapping and this approach does is it gives us a much clearer view of the skills and capabilities that we have in this space, but not just the skills that we have today, those that we will need for the future as well, and more importantly, where those future workforce risks might exist. And then through that framework, we're identifying critical roles as well. And we've done this in partnership with our colleagues in Gartner. We've been able to identify scarce skills, retirement risks, succession challenges, and also this now enables a much more targeted workforce investment and intervention approach. So I mentioned that we're working with Gartner. We've identified benchmarks around critical digital roles, and also the extent to which benchmark tells us investment in that profession is critical. I'm pleased to say that whilst we have got significant training investment in this part of our workforce, external benchmarks also suggest that mature capability-led organisations often invest at higher levels. So that is something for us to consider as we move forward. But it also reinforces the need for us to align our spend, our current spend, much more deliberately to the organisation priorities. And through this work, we're able to see that much more clearly. So our future skills model will focus on the capability that DHCW needs over the next 3 to 5 years. So that's the timescale that we're planning for. And that will include further strengthening in areas such as artificial intelligence, cybersecurity. You've heard Sam talk about that today. Cloud technologies, product management, user-centered design, all things that we've discussed here, and also Welsh language capability. And through this lens, we absolutely want to increase the diversity of our workforce as well. So we want to ensure that we are representing the communities across Wales as well in the workforce that we have. So a deliberate intent around that. So I think this work really shifts us from that vacancy-led approach to capability-led workforce decisions. And this will, having these insights and this data will inform where we recruit, where we invest, where we need to reskill. And again, you will have heard both Sams talk about the need for that, and also the need for strengthened succession plans as well, and building those talent pipelines. And I think this is becoming increasingly important. It's always been important, but particularly in the context of the current recruitment pause and our escalation status, where our ability really to respond through external recruitment is more constrained. So this framework will absolutely help us be much more evidence-based about the roles and capabilities which are most critical to our delivery. And then we can reskill and redeploy existing talent, and where that targeted flexibility may be required to manage workforce service and delivery risk. So it does give us that ability to do that much more effectively. So as colleagues have heard earlier from Sam Lloyd, in terms of the breadth of the work that DHCW is delivering and the prioritised areas that were highlighted by Sam Hall and Rydian, they absolutely depend on having the right skills and capability in place. So this is about creating that professional capability to deliver our ambition and ultimately then to improve the health outcomes for the people of Wales. It's also going to support greater internal mobility to better make use of those transferable skills. And alongside that, we're also establishing an emerging talent programme. So this brings together our apprenticeships, our graduate pathways, work experience, and reskilling opportunities to support a more sustainable grow our own approach as we move forward. You've also heard colleagues talk today about that wider organisation focus on agile methodology and new ways of working. That's come across loud and clear today. And by understanding the skills needed across the product delivery and user-centred design and technology teams, we can then better align and target that workforce development with Scrum and Kanban practices, improved prioritisation, and a much clearer flow and more consistent outcome-focused delivery, which is what we are all about. Marlon, I liked your question around value and impact, and we see that very much being evidenced through improved workforce intelligence around this work, better recruitment and development decisions being made, reduced risk in critical capability areas, and really measurable progress on that role mapping that I talked about earlier, and identification of the skills gaps, that Welsh language capability, the diversity, that internal mobility, and the emerging talent as well, and that targeted investment. So overall, I hope that the board can take assurance that this is a practical delivery of the ambition set out within our people strategy, and the work is absolutely moving now beyond the framework design into more of an applied approach to strengthen workforce planning, guide investment, and manage that capability risk. So critically, this reflects our belief that investing in skills of our workforce and development and potential of our people, that will ultimately improve health outcomes for the citizens of Wales. So in closing, I'd just like to ask the board to note this report and to take assurance of the progress that's being made. I'd also like to recognise and thank my People in OD team who are all central to this work, and the prior investment that we've made in setting up a different structure within People in OD is really starting to yield benefit now and drive value. And also to thank colleagues across DHCW, including union leads, whose expertise and support is really helping us take this from strategy into that practical delivery. So I'm going to pause there now in case there are any questions. Thank you, Chair.
Okay, thank you for that update, Sam. I'll just pause to see if we've got any questions, and I'll go to Helen first. Oh, sorry.
I was letting Paul come in
first.
Oh,
right. Okay. Very noble of you. Right, Paul, you go first, and then Helen come in.
Thank you, Helen. Just a couple of questions if I can, Sam. So just want to be clear on how as an organisation we're defining digital professionals, because I think there might be quite a large cohort of staff who we might not be capturing in that definition and would consider themselves to be digital professionals. And the other element I just wanted to pick up on was with the GDAD framework. You know, I appreciate there's a lot of work gone into aligning us with the GDAD framework, but what are we doing to look after the staff who aren't necessarily captured within GDAD?
Chair, are you happy for me to take those questions first?
Yeah,
yes?
take that one, then we'll go to Helen. Yep, thanks.
Thank you, Paul. Really good questions. And in terms of how we define it, so the GDAD framework has really clear definitions around roles that would fit within that profession. What is true to say, though, is that there are other professions emerging alongside the other professional bodies that we're also looking at. How do we recognise that within the career development space and ensure that we take everybody with us? So whilst we are really focusing on the GDAD framework, as I said, that doesn't mean that other professions are not being included in terms of that investment and that succession planning and those critical skills. And indeed, you know, when we look at the critical skills that we've identified, some of those sit outside of the GDAD framework and will be part of that targeted focus and investment approach. But I think it's a really good question. And I know, Paul, that there are sensitivities with some staff around understanding, does my role fit within that? And we are working with those staff and having conversations with those staff. There's something called the GDAD Plus roles that we're also building, and we're really linking in with our professions around this, and we're helping support the evolution of this approach, I would say. So definitely work in progress, Paul, and something that we absolutely want to take everybody with us on. It's not about leaving people behind or alienating people within this. Thank you.
Thanks, Sam.
Okay, thank you for that, Sam. Helen.
Yeah, just building on that actually. So, you know, it feels like a healthy split, doesn't it? 2/3 are covered under the framework, therefore are, you know, are focused on digital and data roles, and then 1/3 are outside of that in terms of, you know, some being the GDAD Plus, but others being from other professions with their own professional bodies, isn't it? But actually we're one workforce. So this is about ensuring we've got a career framework that is fit for purpose for everybody who works in the organisation. I think the learning management system that Sam's team are implementing at the moment will provide the tooling that's needed for us to have a way of easily managing our own careers, our own development, of that pathway to learning, to evidencing kind of the development that we're making, and investment we're making in our own careers, as well as what we're doing as an organisation. So I think there's a bit of a contract for us, isn't there, you know, between the organisation and each and every member of staff, actually, in terms of the work that's going on. I thought it was a really great report to bring to life. It feels again now, and I'm probably a bit of a broken record today, but it does feel like we're getting a bit of traction now. We've talked about what we're going to do. This now is saying we're moving now into the delivery mode of our people strategy and getting to the kind of, you know, the bite now in terms of the OD that we need to invest in as an organisation right across the piece in terms of our the development of the workforce. I think it's imperative, the professional development of the workforce, and I sit on one of the BCS, the British Computer Society boards, and ensuring that we've got people who are validated professionals, you know, discharging their professional duties, I think is an imperative now, that we've got to step up that that approach in digital and data roles, because we know that lots of people who aren't qualified in digital do digital, lots of people who aren't qualified in data do data, and lots of people who aren't qualified in AI as a new technology will also be taking that forward. How do we collectively be assured that that is being done in the right way? So this work in terms of, you know, encouraging and actually driving the professional development and registration of our workforce is, I think, very timely for what it is that we need to be doing. So yeah, really pleased to receive the report today.
Thank you, Helen. Sam, I just had one point for you. So I think the Grow Your Own strategy, as we've called it, is coming into its own in terms of some of the challenges facing us, particularly with the recruitment freeze. The one thing I just wanted some assurance around was in our escalation feedback, there was some reference to key staff within the organisation who were heavily dependent on. Have we done a sort of succession planning for those individuals, and have a plan for how we get people to the right level to assume those roles if and when they become free?
Really good point. And yes is the answer to that. We have looked at our critical skills and our single points of failure or success, as you might want to term it. And I think a lot of what we have talked about today in terms of the ways of working, the agile working, the Scrum methodology, the Kanban, and the way that we come together as teams will really help address where I think it was more about people having knowledge that hadn't been disseminated widely enough. But I think our new ways of working will absolutely address that, together with that very targeted succession planning and the identification of those critical roles.
Great. I'm really pleased to receive that assurance. Thank you. Thank you, Sam, for that report. We are now running slightly ahead of schedule. So with everybody's indulgence, I'm planning to take Michelle's update on the remit letter now, and then we'll break for lunch after that, if everybody's okay with that. Michelle, over to you, please.
Yeah, thank you, Chair. I may take longer on this one, and then I'll be waiting for their lunch. So I can talk for hours on this. No, so this is obviously an update from the board's perspective. Again, a little bit of context. Board members will recall we considered our integrated medium-term plan in March as a board and agreed the priority deliverables for the organisation for the year ahead. There was an awful lot of work that went into producing that plan right across the organisation. So it's a very robust and worked through plan. Now, the board was not in a position to approve the plan when it met in March. They endorsed, or you endorsed, the priorities within the IMTP for submission, but we had a gap in our funding position at that point, and that was principally around the Digital Priority Investment Fund. So we knew we had initiatives that were priorities for us as an organisation, but we had a funding gap. So I don't want to steal too much of Chris's thunder after lunch then, but we have now got a clear position on the funding allocation quite recently. So that has obviously really helped, and that has helped us to firm up around the IMTP. So just wanted to make that point. We submitted our plan to Welsh Government as is required by the end of March, and then we've received a response. So I think an initial review has been undertaken by Welsh Government. They have indicated that in the background there is a much more in-depth review that they will be working through. But at the end of May, we received a letter from them, and that's I just want to talk a bit about that and the actions that we've taken as a result of that. So the headline of the letter from Welsh Government is that the IMTP as submitted was not currently supportable. So they had some concerns in terms of the plan that they wanted us to address in order to enable them to agree our plan. And that's actually, it's a 3-year plan, I should say. I mentioned the year. It's a 3-year plan, but with quite a lot of focus on this specific year. So they were looking for additional assurance really in the areas of deliverability. So capacity, deliverability, prioritisation, to make sure that we were clear, that we could deliver the ambition of our plan. There were also other areas which I think I'll run through, but which link really to some of the wider escalation themes. So there are areas that we're working on as an organisation. Some of them we would have touched on already today. So around governance, in terms of the way we oversee and delivery, and then also in terms of benefits and value. So how do we demonstrate, how do we build that into our investment decisions? How do we report and demonstrate the impact, if you like, of the priorities that we'd identified in our IMTP? Now, some of those areas are covered, if anyone wants to go and look at the draft, but obviously not to sufficient level of detail in terms of the requirements. So we had a piece of work to do. So number of things were done as we move forward. So we looked at the prioritization aspect. So I think it was pretty clear. The sense was that perhaps there was a bit too much ambition in our plan. Obviously, there's a lot to do in the digital space and lots of things we want to take forward. So we did an exercise. We got together again teams from across the organisation who would have put together the original plan, and we looked at prioritization against a number of different aspects. So the remit letter is obviously our kind of core, and just for those who aren't necessarily familiar, the remit letter, if you like, is our instructions, our requirements from Welsh Government in terms of where they want us to focus for the year ahead, and it also helpfully includes the financial allocation. So it sets the boundaries and it sets the allocation to deliver that. So that's obviously key, and there are many specific requirements set out in our remit letter. We actually got the remit letter around about the middle of March, so limited opportunity to sense check against the IMTP really before sign off at the end of March. So this was a new opportunity, a bit more time if you like, to do that really detailed review. Obviously, then we've got other statutory and policy requirements that we have to meet. We've got, and Sam would have touched on it earlier, we've got a big portfolio of operational services that we deliver across NHS Wales, that NHS Wales obviously relies on. And so service continuity is probably the heading I put that under, is key. So any enhancements, improvements that we need to make to our existing portfolio of products and services to ensure that they continue to operate effectively is another area of priority. As you would expect, patient safety and cybersecurity. So those are very high on the list. Again, any actions that we need to take in those areas. And then the final point in terms of the headlines is the dependencies. So what we often find is quite a complex plan. So we may decide that one thing is our top priority. Actually, we've got a dependency on 3 other deliverables in order for it to deliver value. So we looked at all of that. And we did identify some milestones that that the management team felt could be removed from the IMTP. Right? They were all things that we thought were important that people wanted, but actually against the prioritization, if we were looking at capacity and deliverability, then there were a number of milestones that we identified that we would remove from the IMTP at this point. I should have said, and it's been touched on again by a couple of folks, we've also got the recruitment pause. So again, we looked at that. So we've got, I think, some quite established mechanisms now in the organisation to try and move people around where we can to follow the priorities. But obviously, we will start to see that impact of areas where we've got gaps. So that was part of the consideration. We also looked, and again, some of these are already very much work in progress. Some are areas where we know we need more focus, and we've got more work underway in terms of the response around governance, around dependencies and risk management. So David, you'll be aware risk is something that we've looked at, and risk tolerance in our portfolio delivery committee, for example. So how we manage our risk position across the portfolio. And then I touched on the benefits and value. And in fact, we've got an update coming to the next portfolio delivery committee, which is next week, I think. So we'll be again looking closely at the benefit value position. So that we pulled all that together into a letter. And that went back to the Welsh Government team at the end of June. So I don't think we've had any further update to that, but they are, my understanding is they will be looking at that alongside the baseline review, which was also submitted at the end of June, and other aspects, I'm sure, of the escalation and evidence that we've been providing. So we will wait to see. Just wanted to call out a couple of things then I've touched on. I think in terms of challenges moving forward, we know with our IMTP, we'll have a lot of focus on where we are with delivery. We have seen some funding reductions in the Digital Priorities Investment Fund. So we're doing a deep dive at the moment in terms of any wider implications, in addition to a bit of a delay, I think Sam mentioned, in terms of that being confirmed. So that would have impacted. We're working through that in terms of the detail of the impact. And as I said, the recruitment pause, as we move forward, we'll obviously need to keep a close eye on that in terms of what that actually means to delivery. Like Sam, I'm going to take 2 minutes at the end then, Dave, before lunch, to thank the whole team, particularly the planning team, who've again done a comprehensive job, I think, of revisiting, and all of our kind of key leads right across the organisation who look after our strategic priorities and also our people and how we use our people. So really pleased. And I think the mechanisms, the controls, the tooling that we've put in place in the last year or so really came to bear when we had to run that exercise, and we were able to give a really clear, comprehensive response. So I will stop there.
Okay, thank you for that update, Michelle. Anybody got any questions for Michelle on the remit letter? Helen.
Yeah, again, it's a reflection rather than a question at the moment, as you'd expect. But it's, the amount of work that's gone on here in terms of the adjustment of the plan and the feedback, the initial feedback we've had. I guess just to acknowledge the amount of work, as Michelle has said, by the planning team, by Michelle herself and her team, and the wider organisation. And I guess just being bold, really, there is a better way of doing this by actually co-producing the remit letter. So that is kind of part of the feedback we would want to kind of get acknowledged and work with. And actually, it is acknowledged by colleagues in government. I wonder whether there is a route through now, which is, I think, one of the recommendations that Audit Wales have made, that there is more co-production in the development of the remit letter, so that the plan is developed alongside it, so that we don't have to kind of do these adjustments early in the year that we're trying to deliver the plan. So, and I guess the impact of the delay in the DPIF funding is really helpful. We got our core funding and we were able to move forward with those aspects of the business with the certainty that we did, but the uncertainty will inevitably impact our ability to deliver everything that we've needed to deliver, and then the kind of restrictions, I guess, on the on increasing our headcount or not increasing our headcount, and what that means in terms of us being able to, some of the things that we plan to do in the plan, as Sam Hall suggested earlier, actually, you know, will be affected by the fact that we've got some of those challenges that we've got to overcome in terms of the resourcing model. But you know, just now the getting into the what it means now is the next thing. Is almost that, you know, there's a constant amount of work that the planning team, it's not like the planning team kind of can rest through the summer. They're just, because we'll start the planning again in the autumn, but we're still trying to work through the implications of everything that's happened on this year's plan. So there's an awful lot going on at the moment. But thank you to Michelle and the team.
Yeah, I would like to echo that as well, Helen. Michelle, I've got one question before we wrap up this session, which is, we've now got the remit letter and reworked it, and we've got the DPIP allocations. Are there any gaps between things that are in our remit letter that we are meant to be delivering and the funding that we've got in order to deliver it? Is there any discrepancies between the two?
There are a couple of areas that we are working through, that we're continuing to work through, David. So I don't think we've got complete alignment yet.
Okay.
And actually, probably say the IMTP does move around a bit during the year anyway.
Yeah.
So it's a kind of a live thing. The number of milestones moves around a bit. So we've got change control. So I think there are a couple of areas and a couple of things that have come out of that kind of detailed deep dive now, and will come out of the detailed deep dive around the DPIF funding, I think. So I would expect to see some further kind of refinements, which would obviously need to agree, and we'll manage those through our change control processes now as we move forward.
Yeah. Okay, thanks, Michelle. Helen?
I guess just all of that, but one of the headline areas would be the integrated care record, which is, you know, quite a priority in the remit letter. But even since the remit letter, government are rethinking kind of what needs to happen in that space, acknowledging that it is something that is really important that needs to happen. But actually, is the timing of it quite right, aligning with our colleagues in social care and local authority? So, but we're in active conversation about connecting care and what that looks like, because that is one of the programmes that was agreed in principle in the feedback, but we haven't actually had the funding for that, and that's being discussed and worked through at the moment. So there are still some active conversation in that space in terms of how we could and should be moving some of those things forward.
Okay, yeah, thanks for that, Helen. Before we wrap up this, I would be remiss if I didn't concur with Helen's comments around the timing of this. This is the second year in a row the remit letter has arrived well after our IMT had been submitted. The DPIF pause and review, while I fully appreciate why Welsh Government needed to do that, the timing of that was frankly not good, because we've now created a lot of work for Michelle and the team, which they've risen to the task admirably. But on reflection, we are now 5 months into the new year, and we're only now basically taking the brakes off in terms of delivering all of the things that the system needs. So I'd like to thank Michelle and team, but echo Helen's sentiments that hopefully we'll get an improved position next year where there's co-production of the remit letter before the financial year starts, and any DPIF review, if there is one, is also conducted before the start of the year. So at least we have a clear baseline to work from when the new financial year starts, and that gives us a much better chance of delivering all of the things that we need to deliver as an organisation. So thanks for that, Michelle. We are now 5 minutes a little bit early for the lunch break. So I suggest we take the full half an hour and a little bit more, and we resume at 1:15. Okay, can I just remind everybody to turn their cameras off and mute their microphones during the break? Thank you. Right, welcome back, everyone. We'll proceed with the agenda, and the next item is 6.4, which is our finance report, including our DPIF funding update. And for that, I'm going to hand over to Chris Maud.
Okay, diolch yn fawr, Chair, and prynawn da pawb. We've got some slides to run through, so just wait whilst those upload. And I'll just provide an overview of the 26-27 financial performance. So if you move to the next slide, we'll show what we're going to cover, which will just be the exec summary and then performance against some of our key finance indicators, including revenue, capital, savings. We'll go through the DPIF pause and review update as has been referred to before reviewing the risks and opportunities. So we just stepped through into the executive summary. At the end of June, we're reporting a small revenue underspend of 42k against plan and forecasting achievement of all the key financial targets for the year. In terms of our public sector payment policy, the performance remains strong at 99%, which is above the 95% target, and cash balances remain healthy at 11.1 million. Our capital expenditure totaled 1.826 million against an approved capital limit of 9.152 million. I think the most significant development since the previous board meeting has been the outcome of the Welsh Government DPIF pause and review exercise. So whilst this provides greater clarity and certainty on the funding position for 26-27, it has reduced the anticipated funding envelope by around 5 million and still leaves 14.6 million categorised as agreed in principle pending further assurance. So this remains a key financial risk for us to manage and mitigate through this year. Just touch upon the underlying deficit position. That's also improved. So following discussions with NHS Performance and Improvement colleagues, we've revisited the way we treat the incremental pay pressures, and those have now been removed from the underlying deficit calculation. So that's reduced the recurring deficit from approximately 0.9 million to around 0.1 million. And our objective remains to eliminate this residual deficit through recurrent efficiency measures. The board should also note the latest position regarding the Microsoft VAT case. So HMRC has confirmed the cancellation of the previous assessments and associated interest charges, whilst HMRC has also reserved the right to make future decisions and may issue a new assessment. This represents a positive development for us effectively. And we did explore this matter in some detail at the board briefing session. And we continue to keep our key stakeholders briefed as the position emerges. So we just stepped through to look at then the performance against the financial duties. Based on current forecasts, we're expecting to meet our statutory duties. We're forecasting financial balance at the year end. And capital expenditure remains within the approved funding envelope. As I referred to in the start, the PSPP is strong, as is the cash balance, and that was slightly higher than expected for June, given the Microsoft payout that we have for the new contract starting in July. So moving on to look at revenue performance, again, just to give a brief overview of our Q1 outturn. Directorate performance remains broadly in line with expectation. There are a few variances that are being reported across the directorates, but primarily these reflect some timing issues in terms of vacancy management, the savings profiling, and some one-off expenditure items rather than any underlying budget issues. We are expecting to forecast a break-even position for the end of the year. Several of the areas have had a short-term surplus as a result of the current recruitment controls, whilst other areas have experienced some temporary overspends due to delivery activity or resources returning from completed programs. Again, it's just a note on this slide that the forecast is to break even. If we look at the capital position, so the year-to-date capital expenditure stands at 1.826 million. So we've now received funding approvals for several major programs, including LIMS, RISP, an EPMA, which enables our previously ring-fenced discretionary capital, which the board had approved at the last meeting, that can now be released back into our discretionary capital programme as hoped and as expected. There are, however, several areas that require continued monitoring. So funding confirmation is in progress at the moment for the NHS Wales app and cloud transition programmes. We're expecting those just to go through an administrative process, but they've not officially been added to our capital expenditure letter yet. Whilst the WICIS funding remains subject to further Welsh Government assurance and was one of the items agreed in principle. The board should note that delays in funding approval might affect the delivery timelines and implementation schedules, particularly where partner organisations need to mobilise resources before delivery activity can recommence. So in summary, the capital programme remains affordable, but timely funding decisions remain essential to maintaining our momentum with delivery. So if we move on to look at savings, the IMTP established a savings requirement of 5.74 million, which represents approximately 7% of our core managed expenditure. In terms of the current position, we have identified 83% of savings as recurrent and 17% as non-recurrent. It's a positive position and supports our objective to reduce dependencies on one-off measures non-recurrently, whilst also maintaining a stable workforce position. So the delivery remains on track at this stage of the year, but we need to continue to monitor it throughout the year. In addition, the finance baseline review identified approximately 0.22 million of opportunities to move beyond the break-even position this year. These opportunities will now be considered alongside Welsh Government feedback on the baseline review, and as we again consider the implications of the DPIF review outcome. The main risk to savings is to ensure that the vacancy-related savings are formally embedded, so that savings are not lost once the recruitment restrictions are eventually relaxed. And this is being actively monitored by directors with the support from finance business partners. So looking at the DPIF pause and review outcome, as I mentioned at the start, this is the most significant development since the previous board meeting. And I appreciate that we will have covered this topic in some depth at the board development session last week as well. So colleagues would have had a chance to probe some of the detail that sits behind this. Just as a reminder, the DPIF pause and review was undertaken by Welsh Government and assessed the affordability, delivery confidence, value for money and strategic alignment across the digital portfolio. The outcome has resulted in a revised funding envelope of 55.4 million, which is split as 39.8 million revenue and 15.6 million capital. So as I referred to earlier, that represents a 5 million reduction in revenue in comparison to plan. Several of the schemes have not progressed and others have received the funding allocations agreed in principle. So 14.6 million relating to Connecting Care and WICIS have been agreed in principle and subject to further assurance. The practical financial consequence is that we've currently identified approximately 1.742 million of committed revenue expenditure, which is linked to schemes where funding assurance or formal allocation remains outstanding. I think in terms of the risk position, it represents a significant reduction in risk from the 16.2 million exposure we had previously without the DPIF confirmed funding. But nevertheless, we need to make sure that we continue to monitor that as the year progresses. So we are, as a consequence of this outcome, strengthening our programme level impact assessments, implementing enhanced monthly financial risk reporting, and again, looking at clear assurance plans before any additional commitments are made in this space. And the board should also note that the budget delegation letters have been prepared and will be issued from Helen as Chief Executive to the directors accountable for the DPIF spending. So looking at our opportunities and risks, we've named 3 key opportunities. Firstly, in terms of the baseline review, just to note for the board that this was submitted on time to Welsh Government on the 30th of June, in line with the deadline. This work identified further efficiency opportunities beyond the current savings target, which could strengthen recurrent financial sustainability. But it must be noted that these are challenging, and the 5.74 million savings target in itself represents a significant challenge for the organisation. Secondly, the vacancy management associated with the recruitment freeze provides an opportunity to reshape the establishment costs and to reduce the residual underlying deficit. And thirdly, the cancellation of the Microsoft VAT assessments presents an opportunity, but again, this is subject to further review. In terms of the risks, the principal risk remains the DPIF position. Whilst the funding exposure has reduced significantly, we still have the 1.7 million of committed expenditure, which remains dependent on funding release and assurance approvals. Savings delivery also requires continued focus, particularly ensuring that the vacancy targets are permanently embedded. A further risk is the continued reliance on the time-limited programme funding, which could create workforce and affordability pressures if funding assumptions change. With the majority of our funding position now confirmed, really it's key that we focus on delivery of the remit letter and the DPIF specific deliverables. We'll need to maintain strong financial discipline, and particularly in light of the change in Welsh Government approach to funding DPIF programmes, as this reflects a more ring-fenced basis for this financial year, with payments being linked to milestone delivery. So just in closing, overall, DHCW remains on track to achieve its statutory financial duties, and we're currently forecasting a balanced year-end position, although this remains dependent on the delivery of the savings plan, confirmation of some of the outstanding funding assumptions, and continued active risk management. So we're asking the board to receive and discuss the financial report for June 2026, to note the forecast achievement of the financial duties, note the financial delivery implications of the DPIF review outcome, and to note the continued actions being taken to strengthen financial sustainability, governance and risk management throughout 26-27. So I'll pause there. Thank you, Chair. Happy to take any questions on that.
Okay, thanks, Chris, and thanks to the team again. As with Michelle's team, there's been a lot of additional work required as a result of the DPIF pause and review and the remit letter correlation or reconciliation. Marion.
Diolch, Cadeirydd. Thank you. Can I just thank you first for the clarity of that presentation, Chris. Much appreciated. Can I turn to savings, and you note the balance between recurrent and non-recurrent savings as 83% versus 17%. We know that there's going to be a continuing challenging financial landscape over the medium term at least. What's your level of confidence that we can change that balance and improve on our recurrent savings balanced percentage?
Yeah, I think again in context, Marion, the financial landscape does remain challenging. I think the fact that we're achieving 83% as a recurrent balance is very high at the moment. So again, improving on that, I think will be actually quite difficult. I think the further opportunities that we've got in this financial year are primarily going to be non-recurrent if we're able to deliver additional funds. Looking at the future, so again, settlements for the next year, then we are still looking to work with Welsh Government to explore what a multi-year funding settlement might look like, which would help us with our planning and our position. But I think the focus for us at the moment, and this links strongly to how our savings plan is structured, is on maintaining that stable workforce establishment. So that will and that reflects the majority of our savings plan to date. So it will be kind of embedding that going forward and looking at whether we can establish a slightly longer term and maybe a bit more of a proactive funding settlement with Welsh Government for the next financial year.
Yeah, thank you.
Thanks, Chris. Ruth.
Pnawn da pawb, good to see you all. Chris, it's another confidence question. 14.6 million agreed in principle is quite a lot to be at risk. What's your level of confidence that we're going to meet the required standard to get us to agreed for both of those programmes funding?
Yeah, thanks, Ruth. Happy to take that one, and Michelle might want to contribute as well. I think, again, in terms of the confidence that the funding is available, then I would be confident that the funding is there. I think this is now about us being able to get to an agreed position with Welsh Government on what the agreed deliverables and milestones look like for each of those two initiatives, so for Connecting Care and for WCIS. And obviously the clock is ticking on that, because there's the agreement of the milestones and the deliverables, but the longer this goes on with it being kind of approved in principle, the more challenge we have around delivery, because as David alluded to earlier, we're already at the end of July now. So again, there's the financial aspect and there's the delivery aspect, and the quicker we can get to a position that we can confirm the deliverables with Welsh Government and they are satisfied with those, then I think, again, the more confidence we will have that the funding can be released and actually then utilised.
I mean, I guess that's my question, Chris, is how confident are we that we're going to get to that position quickly enough?
Did Helen want to come in on that? I can see it's got a hand up.
Yeah, thank you. So I believe that the advice on the critical care system is being finalised by officials currently. It's with wider than the digital policy team, is my understanding, and it's once that advice goes up to ministers, then we get the outcome of that. So I believe there's progress in that space. There are a few conditions associated with the Connecting Care money, but I believe that they're being worked into a funding letter that could come out very shortly. So I am feeling more confident, Chair, that we would get it in the in the near future.
Okay, thanks, Helen. Thanks, Chris. Helen, did you have a question as well? Yeah, okay.
Yeah, no, I just a further observation really in terms of Chris's point to response to Marion around kind of multi-year funding settlement and how we get kind of that the stability in our escalation framework with Welsh Government. Actually, that they call out the need for financial sustainability, and they call out that they will help us to support that. So we're not clear what that means, but at our last discussion with NHSP and I, they were going to pick up and get to a more of an understanding of what that means in practice. But I think really helpful that was in the escalation framework.
Yeah, 100%. Okay, Chris, I have one question. The 1.7 million DPIF funding that's still not confirmed because further assurance is required. Can you just flag up which programs are impacted? What assurance are they looking for, and our confidence level around getting to an agreed position soon?
Yeah, sure. So just for clarity, David, the 1.7 million is spend that we have committed that doesn't necessarily have a budget allocation against it. And to be honest, there's a bit of a mix in there. So some will be against, for example, the integrated care record business case, where again, some of that funding, if the connecting care approach is agreed, could be embedded within that. And there's a couple of other areas where we've committed spend that we will just have to look to manage and mitigate against some of our core areas, I think.
Okay, and from memory, the integrated care record was just under $1 million. Is that the right number?
That was the planned figure, although the committed spend against that is much less. That was again in the region of the integrated care record was 0.061 million. So again, just in the board paper cover report, we've set those out in terms of the breakdown of the 1.742 million for connecting care, Welsh Emergency Care Dataset, EPMA, BAU, integrated care record, and the digital intensive care as well.
Okay. Great. Thank you for that clarification. I can't see any further hands, so we've been asked to receive this report. Many thanks, Chris. And we'll now move on to 6.5, the Corporate Risk Register. And for that, I'm going to hand over to Chris Darling.
Diolch, David. Yeah, I'm just going to start with an update, which was mentioned earlier on the programme risk tolerance as a action from our remit letter to look at this specifically. So it's in response to Welsh Government. We have met, as you know, David, as chair of the Portfolio Oversight Delivery Committee. We've met over the last month or so with colleagues from the PMO and programme chairs to strengthen the escalation arrangements around programme risks and programme risk alerts. The remit letter specifically talks about risk tolerance as it relates to major programmes. I think we've probably interpreted that as risks, issues, incidents, and general alerts that Welsh Government should be aware of as early as possible. So that's the interpretation we've taken. But we have agreed, with thanks to the PMO and their work, a process that's consistent now for all programmes that allows an early alert to go to government. As you said earlier, David, I think there's one programme still to meet, but we've done the vast majority of the programmes and worked through, and in doing so just identified what some of the concern areas are looking ahead to the next month to 12 months. So hopefully that will help and address the ask that was set out within the remit letter. So I just wanted to update on that from a risk perspective. And I will just update now on the corporate risk register and the current position. There's 17 corporate risks, 13 of which are included in the papers today. There are 4 which are marked as private risks. And next month, the Digital Governance and Safety Committee will be reviewing those 4 private risks in their closed session. Board members are asked to note just some of the changes since the last board meeting. So 2 new risks have come onto the risk register. We've also removed 5 risks, 3 public and 2 private. And just to specifically mention one, because it's been fairly long-standing, which is 0347, the Radis team scaling back as a result of the risk go live and completion of that programme. So that's that's really good from a risk perspective, because as colleagues will know, that has been on the risk register for quite a little while. In terms of other risks, David, that I was going to just highlight, there's 2 that were added on a couple of months ago that I think have probably been themes throughout the board discussion today. One related to the Digital Priorities Investment Fund pause and review. And I think it's probably fair to say we're still working through what the full impact of that will be from a delivery perspective. It's great that the funding has now been confirmed, but obviously we are a month behind where we could have been in terms of delivery. So that will impact and that risk will be realised to an extent. Clearly, we're going to mitigate as much as we can. The other one that we've talked about relates to the remit letter recruitment pause and the impact that has on a number of things, including delivery, but also including kind of staff morale, etc. I also just wanted to flag two other program risks, but I think Helen covered one, which was the intensive care implementation delay. So I think, Helen, you've probably covered that in the last item in terms of updating the current position. And then the other one was just implementation of WLIMS, which is on track, but board members will be aware it's one that has very close attention from Michelle and from the PMO team in terms of being a risk in terms of delivery. So those were the risks I wanted just to mention. Happy to take questions on any of those or any others.
Okay, yep, thanks for that summary, Chris. Anybody got any questions on any of the risks that Chris has gone through or anything in the report? No, can't see anything, Chris, so thank you for that excellent summary. And we'll move on to the next item, having received that report. And that's 6.6, which is the strategic procurement report. And I'm going to hand over to Chris Morton for that.
Okay, thank you again. So this report seeks approval for two commercial decisions that have progressed through DHCW's governance and management board approval. So are now brought to the SHA board for approval. Specifically, board approval is requested for the award of the new National Intelligent Integrated Audit Solution contract and for a modification to the Welsh Point of Care Testing contract. So taken each in turn, the first decision relates to NIAS, so the National Intelligent Integrated Audit Solution. This is a critical national information governance service that enables NHS Wales to monitor access to patient records and identify inappropriate or unlawful access. The existing solution expires in November 2026. And the proposed new contract will provide a cloud-hosted national audit capability, including support, maintenance, training, and future integration with new national clinical systems. The recommended supplier is Maxwell Stanley Consulting, with a maximum contract value of 4.9 million and an initial 4-year term, together with some optional extensions, which are subject to additional funding controls and scrutiny. So the funding for the initial term is available within approved budgets. NIAS is of strategic importance in that it underpins patient confidentiality, regulatory compliance and public confidence in NHS Wales digital services. The supporting business justification paper identifies significant risks if the contract is not awarded, including undetected data breaches, regulatory action, and potential reputational damage as well. The procurement has been undertaken through a fully competitive process in accordance with the Procurement Act 2023, and the contract award is presented to the board for approval. So I'll just pause there for any questions on that one.
You're on mute, David.
Thank you, Ruth. Any questions for Chris on the NIAS procurement? No, I've just got one. So this has come up a few times on the Digital Governance Safety Committee, and we were concerned about the risk of continuity of service. Now we're bringing this forward. I'm just seeking assurance that we've got continuity of service through the old system and the new procurement. Yeah, I've seen a thumbs up from Lydia, which is what I was hoping to see. Okay, if there's no other questions, I'll just point out that we are still not quite quorate, even though Ruth has joined us. So we will approve this, but it will be subject to a chair's action, which will follow on shortly after the meeting is concluded. Do you want to take us to the next item, please, Chris?
Yeah, sure. Thank you, David. So the second item is the Welsh Point of Care Testing service, which is provided by Siemens. This is a national service that supports approximately 3,000 devices across NHS Wales and processes around 3.5 million tests annually, feeding results into the national laboratory and patient record systems. The current contract expires in September 2026, and all contractual extension options have already been used. The DHCW is seeking approval for a contract modification that would extend the service by up to 3 years and increase the contract value by up to £400,000, resulting in a revised total contract value of 2.257 million. The rationale for the modification is to maintain service continuity whilst we develop the future procurement strategy, funding approvals, and market engagement work for the future WPOCT solution. Currently, we've had some resourcing challenges as some of our resources are tied up in other significant diagnostics programs like LIMS. We've taken external legal advice on this, and the proposed modification is considered acceptable under Regulation 72 of the Public Contract Regulations 2015 on the basis that it doesn't substantially alter the nature or scope of the service. From a financial perspective, the WPOCT costs are recharged to health boards and trusts through SLA arrangements. So the proposal doesn't create a cost pressure for DHCW in 26-27, and any future charges in relation to this will reflect inflation and or service growth as appropriate, which will be agreed with health boards as part of our annual SLA process for future years. So the contract modification and value increase is presented to the board for approval as well. Thank you.
Okay, thank you for that summary, Chris. Anybody got any questions on this? It seems like a sensible approach to me, so we're minded as a board to approve, but because of the courtesy, we'll take a chair's action just to formally do that, Chris, but you have the approval in principle. Okay, if there's nothing else on the strategic procurement report, we'll move on, thank you, Chris, to the performance report, and for that we're going to go to Chris Darling.
Diolch, David. Yeah, I'm going to present the report. There's two elements to the report today. So there's a performance report update against the organisation performance, and then there's the strategic Q1 update in progressing against our strategic missions, which Michelle referenced earlier in terms of tracking our long-term strategy. So I'm going to start with that, which just tracks our progress against ministerial priorities, the NHS Wales planning framework through the lens of our 5 missions. So mission 1, just a couple of headline things in terms of progress. We progressed expanding the care data repository during Q1, completed the clinical coding prototype. But just note in terms of the risks we mentioned earlier, the recruitment pause and DPIF pause and review will have impacted programme delivery from an NDR and other programme perspective in terms of timeframes looking ahead. This quarter also saw DHCW participate in a Welsh Government run cyber incident exercise. In terms of mission 2, Wales participated in the first UK-wide vaccine efficacy analysis using WIS data with reported outcomes. And the GP migrations completed during Q1 to plan to schedule. So that was positive. From a planned care perspective, there were software changes to support the delivery of the modernising outpatients data sets across a number of health boards in June 2026. We also saw the risk programme complete its final go live and confirmation of the planned closure of the programme. From a mission 3 perspective, new governance has been established for the patient-facing digital services, including the NHS Wales app, which is a significant change and a new approach from a NHS Wales app and patient-facing digital services approach to governance. In terms of mission 4, we delivered a number of enhancements to dashboards to support service planning and performance management and insights across NHS Wales, including pelvic fractures, palliative care and falls activity. And from an AI perspective, which is one of the new portfolios in Mission 4, we focused during the quarter on establishing the foundations required to deliver the DHCW AI strategy that's recently been approved by the board. And then finally, just in terms of Mission 5, progress has been made in developing a cultural roadmap for 2026-27, and a strategic workforce capability planning framework has also been drafted. The DHCW strategic advisory group also met during Q1 of this financial year to consider the future role and remit of the group going forward. So those were just some of the headlines from a strategic mission perspective. The second area I wanted to cover was just the headline messages from the organisational performance report itself. And I'm going to start from a workforce perspective, and I will just pause to bring colleagues in at a couple of points. So from a recruitment pause perspective, we know that headcount and turnover are two key areas of focus for us as an organisation and a board. So it's just to note that workforce remains stable during the quarter with a headcount currently at 1,281, supporting organisational resilience and continuity of service delivery, despite some of the ongoing pressures relating to the recruitment pause. Turnover is dropping and has dropped again this month, so it's at its lowest point at 6.19%. If the recruitment pause continues, we would expect to see our headcount plateau and or drop over the coming months based on the turnover and the lack of significant recruitment going forward. Obviously, we can recruit with a business case approved by Welsh Government. The final area from a workforce perspective I just wanted to pause and mention was there was an escalation to the board as part of the performance report at the last meeting relating to PADR compliance, which hadn't achieved its target for a number of months. So pleased to say that it is exceeding its target now at 86.49%. As per the board action at the last meeting, there was a deep dive at the audit committee in July to explore in more detail some of the potential root causes and to note the progress in terms of getting to the point where we have now exceeded the target, clearly sustaining that position and ensuring high quality conversations are taking place as a priority. I will just pause there to see if Sam Morgan wants to come in and comment on anything covered there.
I think you've covered everything off well, Chris. Nothing more to add. Thank you.
Thank you, Sam. Okay, and then just move on then to operational delivery. Service availability decreased from 99.97% in May to 99.76% in June. So this fell below the 99.9% target for the first time in 12 months. This reduction was driven by a major power outage at one of our data centres, which did impact multiple national services. And then a major incident was declared on the 29th of June to address this. And I will just pause again and just hand to Sam Lloyd to update on the work that has taken place since this.
Yeah, thank you, Chris. I'll just give a bit of background and a summary of the incident and then some of the next steps that we're taking. So, as I'm sure members are aware, DHCW operates 2 data centres in 2 separate geographically distributed facilities. These are co-located facilities which are provided and managed by a third-party supplier. We tier our services as well, so we have critical and standard rated services, and the critical services are subject to a higher level of availability and a higher level of operational support. All of our critical services, and in fact most of the standard services, run from both data centres, so they can be failed over from one to the other, and they can run from either, so that we can be, in theory, independent of data centre issues. So the facility that was affected, we have experienced heat issues there previously. So we've had 2 heat-related failures to that facility. So in the immediate run-up to this incident, obviously not being aware that it was going to happen, there was a heat wave that occurred where the temperatures were very high. So this was the 36-degree temperatures that we had that week. So our teams took the preemptive decision to fail all live services across to the other data centre, which proved to be a very fortuitous decision because the impact was much reduced of this incident as a result of that. There were several power power disruptions in the national grid in that area, which occurred in the days before this incident. But then on the 29th of June at around about 12:40, there was a complete failure of power to the facility. There were a number of backup arrangements in the facility which should have prevented this from resulting in the outage that it did. So we have backup generators, or the supplier has backup generators. They also have what's called uninterrupted power supplies or uninterruptible power supplies, which are large batteries which are designed to take the load for a bit in order for us to shut down services gracefully. None of that worked, and the facility went offline. So that meant that all equipment running in there was powered off. However, as a result of the resilience mechanisms that we have in place and that prior to decision to fail over, the impact was significantly reduced. So we were, I think that action proved to be sensible, and the measures that we've put in place mean that we have a high degree of resilience against these kind of incidents. That said, there were still some service impacts because it's a very complicated, interrelated set of systems, and we always find there are some dependencies when we have an unscheduled event of this nature. So some services were degraded, some critical services, but that degradation was recovered pretty quickly. And some of the systems, there's a very small number of systems which don't have that cross-site resilience, and obviously they were fully impacted. Most of those are in the information services sort of dashboarding kind of world, which rely on the data warehouses. And so we had some issues with recovering those. By the end of the same day, all of the critical services were available, although there was some degradation which continued into the next day. So we contained the significant impact quite well. We have recently established a new major incident management team who act as a central point of coordination for incidents and ensure that we have consistent comms and processes are followed. This was their first major incident, so it's quite a big one for them to cut their teeth on. I think that said, they did a good job. There are some lessons to be learned from it around communications, particularly, I think, which we are stirring into the process improvement. We kept stakeholders informed with regular communications on our Teams channels and other routes. We kept Welsh Government and other key stakeholders up to speed. By the 3rd of July, all of the residual service issues that we were experiencing had been resolved. We didn't declare the major incident fully resolved at that point because there were still some issues with resilience across the two facilities. Some equipment had been damaged or had its configuration damaged because kit like that doesn't like to just have its power pulled, obviously. So that did cause some problems, which then took a few more days to resolve. So we declared all services fully restored on the 14th of July. Number of lessons learned that we're taking from that. So we've got an enterprise monitoring capability which we're establishing at the moment. We need that to be operating quickly. There are some process improvements around communications and things that I mentioned. The most of the issues, the vast majority of the issues, sit with the supplier, and as you can imagine, we're working closely with them to resolve those. And one of the things that we're doing is having a third-party independent review of the facility, which will cover both the way it's configured and the way that it's operated and managed. And obviously the longer term mitigation to these kind of risks is through the cloud migration. One of the reasons we're doing this is to reduce dependency on data center facility. As Chris said, this did impact our availability statistics for the month, and they fell below target. Over the year to date, though, we are still above our 99.9%, but that doesn't take anything away from the seriousness of the incident. And obviously, we're working through the implications of that. Thanks.
Diolch yn fawr, Sam. I'll just run through. I've just got a couple more points to cover. So the service desk satisfaction continues to exceed its target at 97.4%. And just to note, use of the electronic prescription service continues to expand. The number of live sites are increasing with over 900, demonstrating ongoing rollout and adoption across primary care. Similarly, with the NHS Wales app and usage there, I won't go through the numbers. I know Sam covered that earlier, but again, positive to see that continue. And just finally to mention, the dormant accounts across NHS Wales have reduced. This was the second area of escalation that we discussed at the last board meeting. So that's positive to see that, and suggests that there's some impact from the work Sam and the team are doing from a cyber perspective and the focus on cyber. So really helpful and good to see that. Just to conclude, there's no performance issues for escalation per se. I do want the board to note the impact of the major incident during the period and just note the DPIF pause and review and the potential impact on future delivery, and that still needs to be fully worked through. So I'll stop there, David.
Okay, thank you for that, Chris, and to Sam for the detailed explanation of the major incident that occurred. Anybody got any questions for Chris? Start with Ruth.
Thanks, David. Thanks, Chris, for that update. Comment first of all, well done to the service desk for exceeding the service levels. Good effort, and keep up the good work. That's really pleasing to hear. Second question, and it might be Sam Morgan who comes in on this, around the recruitment pause. I think one of the opportunities we were hoping to see from the recruitment pause is that it would give opportunities to people within our organisation to move around that had perhaps not done that previously. So I just wondered what our progress has been like in terms of the recruitment pause supporting our wish for a more flexible organisation or identifying opportunities for people within DHCW. Diolch.
I'm happy to come in there, Chair, if that's
okay.
Please. Yeah, so it's a really good question, Ruth. And so this would form part of what our strategic resourcing oversight group is working on at the moment, and there have been some really good examples of people moving into different roles. So it is proving to be a vehicle for enabling that to happen. That said, it's not creating additional capacity, so it's just moving capacity from one area to the other, and we still have got areas where we just can't match the skills from one area to another. So, this will take time. And, earlier on today, I presented a paper on strategic workforce planning, and that is going to be critical to enabling us to have a more agile organisation so that we can support these really hard to recruit to areas or areas that it takes a long time for skills to build up in. But yes, that is making progress. And I've asked the team actually to do a report around what that is delivering to our organisation. I think it's been a really good exercise to help us think about the agility of skills across the organisation and to work in a less siloed way. So yeah, thank you.
Okay, thank you, Sam. Helen.
Thank you, David. I just want to echo my thanks also. The incident was dealt with so efficiently by our teams, but clearly a great cause for concern, but really well done to everybody involved. And just wanted a query, Chris, and you may not be able to be fair to you answer because it's a bit of a detailed one, but we're monitoring the engagement activity, and I know that we're doing a lot of work in terms of the redesign of the performance report. We specifically call out business change engagement. I wonder whether we are ensuring that we are recording. We've shifted the way we work now, haven't we? And we have an awful lot of engagement across teams in the product way of working, and we have show and tells, and we have kind of lots of groups in place where we are engaging through the UCD process with our stakeholders. So at the moment, are we capturing that activity, or have we still got work to do to ensure we are capturing that level of engagement?
I think there's still work to do, Helen, to improve the engagement that we are capturing. It's one of the reasons, actually, I appreciate the chair's comments on the service desk, because that is over 200,000 individuals interacting with the organisation and coming away with a very positive satisfaction rating. But things like show and tells, I mean, how we quantify some of the engagement and feedback, I think we need to work through. The business change is being captured in the same way, but clearly that model is changing going forward from a product working perspective. So I think it's probably one for us to keep and make sure that with the changes to the performance report, they are fully reflecting all the engagement that we're doing, because we know some of the big data events, etc., we get really positive feedback from stakeholders that engage. The digital conference a couple of months ago, the feedback from that, very positive. That's not currently featuring, Helen. It does need to going forward.
Okay, thank you for that, Chris. Marion.
Thank you. Just a couple of observations, really. Very pleased to see the number of dormant accounts reducing. It's been a key cyber risk for us, and I know there appeared to be a lack of awareness of this issue across certainly some health board leaders. So really good to see that. And then just to reiterate Chris's comments about the PADR, we did a deep dive 2 weeks ago at our Audit and Assurance Committee. At that time, it showed that compliance had improved from 80.38% to 87.6%, well exceeding the target. And I guess from the figures we heard earlier now, it just shows that this is very much a moving feast. So the challenge will be to maintain this. You know, it's a real important area for us, but I think, got a level of assurance that there are enhanced controls in place now to make sure that we are able to sustain compliance more consistently across the year. So diolch.
Okay, thanks, Marion. Chris, is there anything further you wanted to say before we move on? No. Okay, many thanks for that update. We're receiving that report. We're now moving on to 6.8, which is our committee highlights report. And I'm first going to go to Sam, who's the co-chair of the Local Partnership Forum. Over to you, Sam Morgan.
Thank you, Chair. I wasn't actually at the last Partnership Forum meeting, so I think Paul chaired the one that's come to you this time.
Fine. So, in which case, let's default to Paul if he's happy to pick it up.
Apologies.
I think that's wrong, Sam. I was on holidays for the last one.
Okay.
You chaired it.
Okay.
Sorry.
Apologies. Okay, just bear with me. Okay, so the report, as you can see, set out in front of you, just summarises the work of the Local Partnership Forum. It continues to be a key vehicle for us to keep our workforce agenda right on point. We continue to shine a light on elements of ED&I. I think that's become front and centre, and also partnership working and compliance with the partnership duties as well. So there's nothing extraordinary to report in that report, other than to say that it continues to be a really good forum for us to discuss issues that affect our staff. Thank you.
Okay, thank you for that, Sam. Has anybody got any questions or comments? No, great. Okay, let's move on to the Remuneration and Terms of Service Committee. I'll cover this. The meeting received, the committee received assurance about the end-of-year performance summaries for our executive team, and reviewed and discussed the objectives for the coming financial year 26-27. And we approved, subject to Welsh Government further approval, an extension to the interim Executive Director of Finance arrangement through to the 31st of December this year. Those are the main things that were discussed. I'll happily take questions or comments if anybody's got any. Okay, great. So we'll move on then to the Audit and Assurance Committee, and we're going to Marion for an update.
Diolch yn fawr, Cadeirydd, ac mae'n bleser gen I gyflwyno'r adroddiad yma sydd yn adlewyrchu yn prif bynciau trafod yn cyfarfod pwyllgor ar Orffennaf y 14/10. Dim byd mawr I adrodd, ond gai jyst yn eich sylw chi at sgwpl o'r adolygiadau a ddaeth ger yn bron ni. Mi gaethon ni wybodaeth adolygiad gan raglen wybodaeth gofal dwys Cymru. A mi gaethon ni gan yr archwilwyr mewnol sicrwydd clir bod llywodraethiant, trosolwg ag trefniadau ymgysylltiad rhanddeiliad wedi cryfhau yn sylweddol ers yr adolygiad annibynnol a gafwyd yn flaenorol. Ac yn ail gan archwilio Cymru, fe dderbynion ni adroddiad adolygiad trawsnewid digidol. Fe gofiwch chi bod hwn yn adroddiad roedden ni wedi aros yn eiddgar amdano fo ers rhai misoedd, ac braf go cael y sicrwydd hwnnw yn bod ni yn symud i'r cyfeiriad iawn ar y maes yna. A wedyn, yn ola falle, yn sesiwn breifat, mi dderbynion ni adolygiad ar ein prosesau recriwtio. Siomedig ar y naill law bod yr graddfa sicrwydd yn gyfyngedig, ond braf iawn gweld bod na waith caled wedi bod yn digwydd yn y maes yma, ac yn amlwg bod na gamau gweithredu wedi cael eu cymryd i wella'r sefyllfa, ond mi fyddwn ni fel pwyllgor yn parhau i edrych am sicrwydd pellach yn ystod y flwyddyn i ddod. Ac yn ola, mi oedd yna nifer o strategaethau a pholisïau hefyd, fel y gwelwch chi o'r adroddiad, gath ei gymeradwyo gan y pwyllgor. Dim mwy i wadrodd, ond hapus i gymryd sylwadau neu gwestiynau os ydych chi'n dymuno gwneud hynny. Diolch yn fawr.
Okay, thank you, Marion. Anybody got any questions for Marion or comments on the Audit and Assurance Committee report? Okay, I can't see anything, so we're receiving those reports for assurance, and I'm now moving us on to part 7 of our agenda, which is closing matters. First item is AOB, any other business. I've not received anything in advance of the meeting, so I'll just pause and see if any colleagues have got anything they wish to raise under this agenda item. No, great. Let's move on then to close the meeting. I'll just remind everybody that our next meeting is on Thursday, 24th of September. I'd like to thank all colleagues who've joined today for their presence and for the content and discussion we've had. One final reminder that our AGM is today at 3:30, and anybody externally listening in are welcome to join us. And with that, I'll close the meeting and say diolch. Thank you.